So good afternoon. Today we will start GIT iFile part 2, and we are going to collect iFiles for paper 1. Dr. Mustafa ENT, Dr. Olivia McBain, Dr. Ahmed, all of you, you can find a button known as raise your hand. So you can raise your hand to participate, not watching, just solve, and we will rule out or confirm your answer together. Okay, so Dr. Ahmed, I will start with Dr. Ahmed. All of you, you can unmute yourself. You can, Dr. Ahmed. يلا دكتور أحمد. Your voice is not clear.
Now voice good?
Yes, now is good. Anyone with a clear voice, please start with me.
Reda,
Yes.
I am with you.
طب يلا go on.
بسم الله الرحمن الرحيم. Complications of Gallstone. A 40-year-old woman presents with acute abdominal pain in the epigastrium and the right upper quadrant. The patient rolls in agony and has had 2 episodes of vomiting. On examination, she is tachycardic and sweating. There is rigidity in the upper abdomen. Can I see the answers, please, Dr. Reda? This is biliary colic.
Okay, next one.
A 45-year-old woman presents with acute pain in the right upper quadrant. On examination, she has fever 38.5, tachycardia, hypotension, blood pressure 90/70 millimeter mercury. A tender mass is felt in the right upper quadrant. Fever mass. I think this is myeloma.
Brilliant, thank you. Okay, I will start to conclude in just lines. Any right upper quadrant pain is biliary colic. Okay, but here you see that there is vomiting, tachycardia, and sweating, and the patient is roll in agony with guarding, okay, or rigidity. This rigidity is due to severe colic, either renal colic, biliary colic. This pain will make the patient in severe agony with rolling. If these signs are for peritonitis, then you will find other features of peritonitis. He will tell you about fever clinically and about TLC laboratory. Okay, so we have neither fever or TLC, and this type of rigidity with rolling does not confirm peritonitis. Why? Because peritonitis, the patient will be still meaning that he couldn't move and do this rolling movement because of the severe peritonitis. So this type of rigidity due to just pain, and also sweating and tachycardia because of this pain. So don't worry that it's a peritonitis. It's not peritonitis. It is just biliary colic. Okay, I will start with you. Last picture and very brief about gallstone disease. Okay, first, this is gallstone disease. Most patients with gallstone disease are asymptomatic, okay? But if the stone goes to Hartmann or cystic duct or CBD, then you will have what's named as biliary colic, severe pain that can last for hours. Several hours later, this blockage will lead to stasis in the secretion, and you will find laboratory finding of inflammatory process, which is cholecystitis. So you will find fever and elevated TLC. Okay. This cholecystitis can progress with this blockage. Secretions will be retained. Okay, within hours to days, this can lead to right upper quadrant mass and just pain. This is called empyema. Just clear fluids, mucoid fluids, because as you know, the gallbladder lined by columnar secretory epithelium. So it can secrete because the blockage here prevents these secretions to go out. So just empyema. Then if this got infected, then it can progress to, this is mucocele, can progress to empyema or biocele. So you will find right upper quadrant pain and mass and fever, because this is abscess, but so it is empyema, not mucocele. Okay, again we will return back to this. Acute cholecystitis can progress to cholelithiasis or just isolated CBD stones. You will find that the cells lining the biliary tree, okay, will secrete cholestatic enzymes like alkaline phosphatase and gamma GT, by the way, gamma glutamyl transferase. But this gamma glutamyl transferase only be done when you are afraid to be a bone disease. Why? Because alkaline phosphatase will be raised in bone disorders and cholestasis and sometimes of malignancy. But gamma GT will only raised in liver or biliary tree problem and also other tissues, but not in bone disorders. Okay. Plus, you will find bilirubin is elevated because the bilirubin couldn't go there, so you will find a picture of obstructive jaundice. So bilirubin profile will be raised. Then, if this blockage with a secondary imposed infection, then you will find a biliary sepsis, which is ascending cholangitis. You will find pain, fever, and jaundice. Everything. This is a picture of sepsis and obstruction. Okay, so you'll find pain, fever, jaundice, or hypotension and altered mental state, Charcot triad or Reynolds Pentad. Okay, this is made easy and made simple. In January 2018 exam, this question came. A 50-year-old woman presents with a history of right upper quadrant pain and jaundice. She reports that her urine was dark in color and her stools are offensive and difficult to flush. Difficult to flush meaning
Steatorrhea.
steatorrhea, okay? Because of fat malabsorption, because of blockage
Bile
and
ulcer.
no ability of the bile to go for the intestinal lumen. So what do you think? Can you tell me in the chat what is the answer? A, B, C, D. From the previous lecture and this lecture, can you tell me in the chat what is your answer? Very good. So now many people previously answered this reduced enterohepatic circulation, okay? And this is very wrong, okay? So increase in conjugated bilirubinemia, yes. Increase in unconjugated, it is already insoluble, so it couldn't go to urine, okay? Increase in urea, this is wrong. Urinary urobilinogen, this is wrong also because urobilinogen will come from the intestine itself because it is the same as stercobilinogen that will return back to the bloodstream and the liver and go in urine. But already there is a blockage. So this blockage will prevent direct bilirubin to go to the intestine. So no stercobilinogen, so clay stool, and no urobilinogen. So you will find minimal amounts of urobilinogen in urine in obstructive jaundice. Okay. So again, conjugated bilirubin can be excreted via the urine because it is water soluble. But unconjugated couldn't because it is insoluble. So dark or Coca-Cola urine will be manifesting conjugated or mixed hyperbilirubinemia. But normal urine is seen in unconjugated disease, which is meaning of hemolysis or conjugated problems in the liver, like we see Crigler-Najjar syndrome, Gilbert, and also Reuter syndrome and Dubin-Johnson. So those with obstructed picture will go to have pale stool due to reduced level of stercobilin entering the GIT tract. Again, the same problem, why clay stool? As we said, direct bilirubin is supposed to reach from the liver to the intestine. For this direct bilirubin to be converted to stercobilin, then the stool should be dark, okay? But now no, because of obstruction, no direct bilirubin will reach, then it should be discolored or clay colored. Dark urine, because of direct bilirubin, is water soluble, and we reach it here to the point. Number two, it's pain, fever, mass, so it is empyema of the gallbladder. Next one.
I continue, Dr. Reda.
No, I need more one. You can, all of you, this time, all of you, you can open your mic, but only people with unnoisy background, please. So anyone can now tell us to open his mic, apart from Dr. Mustafa, you have done. Thank you very much.
Me, Dr. Reda.
Yes, go on. Okay, you can start. يلا اللي عايز يبدأ يبدأ. طيب يلا. Anyone want to start? Please start.
Yes.
Yes, go on.
A 35-year-old lady present with fever and malaria and loss. She has been passing dark urine and pale stool. Examination suggests hepatomegaly. Liver function tests show a raised AST. Tests are positive for antibody.
I don't know. يعني when I open the mics for you to be just with me and make it a very competitive and very good discussions, then many people with noisy background open the mic and leave it. Okay, what's from me supposed, or what's supposed from me to do? Open the mic or not?
Can I read?
You
Can I
able
read?
to unmute yourself or not?
Can I read, دكتور رضا؟
هو حضرتك اللي كنت بتقرا ولا مين؟
مش عارف. أنا كنت
Yes, اللي كان يقرا يفتح المايك. You are able to open the mic, but people with noisy background, please don't open your mic.
I thought myself I was talking alone. I thought this was unmute. Can I see the option again, please?
Yes.
So we have amenorrhea, we have weight loss, we have passing dark. So we have, I think, post-hepatic obstruction.
Primary biliary cirrhosis.
Tell me your answer and we will conclude and make a summary at the end.
Can you help me, Dr. Reda?
Yes, I hear you.
Can you help me and help me?
You have hepatomegaly. Okay. You have multiple autoimmune antibodies like this one. Okay, and you have liver disease, liver cell failure like AST elevated, and you have also obstructive picture, obstructive jaundice picture. Only this. Leave amenorrhea, no problem. So what do you think?
Primary biliary cirrhosis.
Primary biliary cirrhosis. Primary biliary cirrhosis.
No.
Autoimmune hepatitis.
Autoimmune hepatitis. Brilliant.
Why
not? First of all, why not this one is not primary biliary cirrhosis? Because no AMA and no other autoimmune disease like Sjogren or rheumatoid arthritis, many other. No this. So plus the age is 40s to 60s of primary biliary cirrhosis. So it's not primary biliary cirrhosis. So what do you think?
Autoimmune?
Yes, autoimmune. So when you have fever, anorexia, headache, malaise, this hepatitis, okay? Plus you have here idiopathic, you couldn't rule out the cause. So this is autoimmune. So fever, anorexia, headache, malaise with hepatomegaly and elevated liver enzymes. So this with multiple I will block I will mute all, okay, until you. Okay, so multiple autoantibodies. So this is supposed to be autoantibodies that go to the liver cells and destruct them. Okay, but why dark urine and clay stool? Because what do you know is in hepatocellular injury, there is intrahepatic biliary tree are going to be obstructed. So you will have the same picture of mixed hepatic and post-hepatic jaundice. So you have obstructive picture. Again, why? Because in liver cell failure or liver disease, you have liver cell injury, destruction of the construction of the liver, then you have obstructive picture because of the affection of intrahepatic biliary tree and obstruction. So this is autoimmune disease. Again, fever, headache, fever, anorexia, headache, malaise, hepatomegaly, or shrunken liver may be due to cirrhosis, and also elevated enzymes like AST or ALT, or both of them. And also you will have autoimmune antibodies. Next one.
A 45-year-old lady present with a recent onset of. She has had lethargy and pruritus for many months, which she has self-treated with over-the-counter energy pills and antihistamines. Examination reveals jaundice and hepatomegaly and splenomegaly. Tests for anti-mitochondrial antibody are positive. So we have the problem in the liver. Primary biliary cirrhosis.
Brilliant. Again, female 40s to 60s with liver injury and also obstructive picture because of the affection of intrahepatic biliary tree with characteristic itching, xanthelasma, positive AMA, and association with Sjogren rheumatoid arthritis. So this is primary biliary cirrhosis. The same example of April 2018 exam. Next.
A 50-year-old lady present with tiredness and weakness and dyspnea on mild exertion, on a sore red tongue and diarrhea. Test for anti-intrinsic factor antibody is positive. Can I see option again, please? She has pernicious anemia.
Pernicious anemia. Simply, when we eat, we have vitamin B12 or cobalamin. This will go to the stomach, and parietal cells in the stomach has a dual function, will secrete HCl and intrinsic factor. This intrinsic factor will be activated by HCl, okay? Once you have intrinsic factor, B12 complex this binding between B12 and intrinsic factor will occur in the duodenum. Then at the terminal ileum, the B12 will be absorbed. In pernicious anemia, you will have autoantibody for the intrinsic factor. Then no ability to absorb B12. Again, you have a parietal cell, parietal or oxyntic cell, it is the same name, secreting HCl and intrinsic factor, will unite with B12 making intrinsic factor B12 complex that will be absorbed in the terminal ileum. When you have in pernicious anemia, intrinsic factor antibody, there will no absorption of B12, which is essential for RBC synthesis and neurological integrity. Next.
A 50-year-old obese lady present with fever, intermittent and colic right upper quadrant abdominal pain and jaundice. Examination elicited tenderness in the epigastrium and right hypochondrium. So fever, colic upper quadrant, jaundice. So it have cholangitis or like she has cholangitis.
You have to be like ascending cholangitis. In your exam, by the way, you have to be very confident, even if you are sure you are wrong, because this will benefit you. I know it's not good to say that, but the confidence, self-confidence will make you put the correct answers and will be more beneficial for you than being hesitated. Pain, fever, jaundice, yes, ascending cholangitis. If I said no, it's wrong, and your mind said no, it's wrong, or maybe like that, this is hesitance, and this hesitating answers will be wrong. Whatever, if they are correct, they will be wrong too. Okay, so ascending cholangitis. يعني عامل لك ايه تاني؟ جايب لك رسمه وعامل لك ماشي. اوكي، يعني بين فيفر جوندس تشاركوتس، يبقى اسمها ايه؟ ascending cholangitis. اوكي تمام. ثانك يو دكتور مصطفى. دكتور هيفا or دكتور عدي or دكتور احمد, you can open your mic. يلا دكتور هيفا. طيب دكتور حسين فرح. يا جماعه عايزين ننجز يعني. حد يفتح المايك ويتكلم.
على شوف زينة رمضان يا ماما.
حد من اللي جاوب قبل كده ممكن يجاوب تاني ولا؟
طبعا ممكن عشان نخلص، بس عايزين نخلص المره دي اكبر
أيوة
عدد
دكتور
ممكن.
معاك يا
طب
دكتور
يلا.
رضا.
يا دكتور رضا.
السلام عليكم. يلا كلنا نشارك. اللي هيتكلم اول واحد يبقى دوره، عشان انا مش عارف افتح المايك للناس. يلا
تمام.
بس حضرتك اللي هتبقى الدور ده ان شاء الله.
فين طيب السؤال؟
يا جدعان اوكي يلا جو اون. Gallstone problems, acute cholecystitis and all of that. Yes, your voice is very nice. Go on.
تمام. 75-year-old lady presents with severe colic central abdominal pain and vomiting. Examination reveals right upper quadrant tenderness and abdominal distension. Bowel sounds are hyper peristaltic and tinkling in nature. Supine abdominal film confirms the presence of multiple central fluid levels and air fluid level in the biliary. Here Gallstone Elias.
10 على 10 next. Brilliant.
A 48-year-old obese lady presents with a 4-day history of severe upper abdominal pain radiating to the back and vomiting. Examination reveals marked tachycardia and generalized upper abdominal tenderness. The obese, severe upper abdominal pain radiating to the back and vomiting. marked tachycardia.
acute pancreatitis.
ممكن اشوف الاجابات طيب معلش الانسرز. acute pancreatitis mostly acute pancreatitis.
Yes. Female, fatty, 40s, 50s, filthy, wealthy, with central or right upper quadrant pain radiating to the back with instability, because you know young people admitted in the ICU, in the general surgery wards, then the ITU, then they are going to die. Okay, because acute pancreatitis is a fatal problem. If not treated well, it can progress to severe acute pancreatitis with deranged everything until multiple organ failure. So this instability due to acute pancreatitis, pain radiating to the back, severe in nature, with news or national early warning score high due to tachycardia and many types of instability, tachycardia, hypotension due to fluid sequestration, and fever because it is itis, it is inflammation. So you can have acute pancreatitis with its severe picture until into multiple organ failure. Next one.
كمل.
Tumor markers. لا ما تكملش. اللي بعدك دكتور وداد، دكتور أحمد، دكتور عدي. You can start please. Yes.
Okay.
دكتور هيفا go on. زين دكتور عدي. يلا دكتور هيفا. Yes, go on دكتور هيفا. طب دكتور عدي.
Yeah. So the first one is hepatoma. And for hepatoma, can I see the options once, please?
Alpha fetoprotein.
Alpha fetoprotein.
Alpha fetoprotein.
هياكلوك. They will eat you. Okay. Go on.
Yeah. Ovarian carcinoma.
125.
CA125.
CA125. Prostate is PSA. Colorectal is CEA. Multiple myeloma.
S100.
No.
Alkaline phosphatase.
Alkaline phosphatase.
S100 for melanoma.
Melanoma, multiple malignant
Yes.
melanoma.
Pancreatic.
CA
15.
15.
19.
95.
99.
99. Yeah.
99.
Okay, last picture. I made this for you just to remember. Gallstone medullary thyroid carcinoma. Thyroglobulin papillary thyroid carcinoma or follicular thyroid carcinoma. Breast CEA 15.3, CEA 27.29, CEA 1.25, which is the same as for the ovary, and also CEA, which is the same for colorectal tumor. Hepatoma or hepatocellular carcinoma, alpha fetoprotein. Testis, seminoma, HCG.
Beta hemoglobin.
Seminoma, HCG. Teratoma,
Alpha
protein.
feto.
No
DT.
S in teratoma, so it is alpha
DT.
fetoprotein. But seminoma, HCG. Don't forget that. Pancreas, 19.9.
19.
Small cell lung cancer, neuron specific enolase. Prostatic cancer, alkaline phosphatase or PSA.
So, multiple myeloma, it is paraprotein.
Paraproteins.
Yes.
Not alkaline phosphatase.
Okay.
Okay. Plasma cell tumor or multiple myeloma, you have CRAB criteria. CRAB means calcium, renal, anemia, bone lesions, lytic or worm-eaten appearance of the skull or any bone, anemia, creatinine elevated, renal insufficiency, and CRAB, calcium. Associated with elevated paraproteins, Benz-Jones proteins, beta microglobulin, IgG, M light chains, paraproteins, all of this are the same name. Okay, so this is plasma cell tumor or multiple myeloma. It is the most common primary bone tumor. I know it's going to be slow, but I think this is more enjoyable than being with only studying like questions only. Okay, now I have a good collection from the iFile, which is primary biliary cirrhosis. You know it from the, as we said, female 40s to 50s, itching, AMA, and any autoimmune disease, rheumatoid, Sjogren, or anyone. Sclerosing, as we said, it is a skill, both intra and extrahepatic, male and middle-aged, with also pain, fever, jaundice, but you have another anti-nuclear antibody or ANCA, okay? And AMA is negative because it is here in this, it is a feature for primary biliary cirrhosis and also associated with C. ulcerative colitis, which is inflammatory bowel disease, especially ulcerative colitis, okay? Liver cell disease, all of these are signs of liver cell failure, as we said, gynecomastia, Dupuytren contracture, flapping tremors, and chronic liver disease associated with emphysema, diabetes, and also alpha fetoprotein deficiency and Wilson or hemochromatosis, okay? Don't forget this disease, alpha fetoprotein, alpha 1 antitrypsin deficiency. So you can find lung disease because this enzyme is essential for integrity and for the surfactant of the lung. Bronze Jones diabetes and tanned skin with iron deposition, which is hemochromatosis, and Wilson disease, copper, inborn error of metabolism associated with CU, which is copper deposition in CNS, and joints,
KF rings.
and Kaiser-Fleischer rings of the iris, of the eye. As we said, the previous question was sentinel lobe, dilated small bowel lobe in acute pancreatitis. Air under diaphragm, perforated viscous. Inverted U-lobe or coffee bean signs, sigmoid volvulus. Loss of hostrations, ulcerative colitis. What is hostration? In ulcerative colitis, you have in any AXR, abdomen X-ray, you will have this history. When this lost as lead pipe, then this name as severe ulcerative colitis. This will be apparent in X-ray. Couple stoning, as we said the previous lecture, Crohn's disease. Apple core lesion, cancer, because it is like this. Follicular carcinoma, woman with solitary lesion and hematogenous spread. Follicular, not lymph, it is blood. Papillary, you have blood and two features, orphan ani and Samoma batis with lymphatic spread. So you can find pulsatile, you will find cervical lymphadenopathy or any lymphadenopathy. This is papillary. But follicular, blood spread, and we know the MRCS question scenarios. Anaplastic, rapidly progressive, aggressive, compressive. Medullary may be sporadic, isolated, or part of MIN1, MIN2, 2A, or 2B. Lymphoma, hepatosplenomegaly, night sweating. I will leave all of this for you to read. As you see, it's very specific. Next one. Anyone can read and can answer.
Can I join?
Yes.
I will read the options. Carcinoma of the duodenum, cholelithiasis, chronic active hepatitis, chronic pancreatitis, echinocosis, gastric carcinoma, Gilbert syndrome, hepatitis C, hepatocellular carcinoma, primary biliary cirrhosis. 55-year-old man who had undergone a total colectomy 30 years previously for familial adenomatous polyposis, presenting with a 3-week history of painless jaundice with a passage of pale stool and dark urine, anorexia, weight loss, and vomiting. It is carcinoma of the duodenum. Number A. Because in familial adenomatous polyposis, duodenal carcinoma is more common than gastric.
99%.
73, 80-year-old man admitted as surgical emergency with severe epigastric pain,
No,
jaundice,
sorry.
fever.
Oh, another one, because this is a scanned April exam. So you have done this question. And next
Yes.
one. Anyone apart from you? Thank you very much.
Can I answer, please?
Yes, go on.
An 80-year-old man is admitted as a surgical emergency with severe epigastric pain, jaundice, fever, and rigors. He gives a history of intermittent attacks of similar pain in the previous 5 years. في التشاركو triad. Can I see the answer, please? Colidocolysis.
Impacted stone.
Colidocolysis
Yes,
is complicated
it
by
is.
cholangitis.
Yes, actually, it is ascending cholangitis. Okay.
Because
But
impacted stone.
yes, but here no ascending cholangitis. So from the previous picture and from your knowledge as surgeons, you know that we may choose a colidocolithiasis or CBD stone as the ascending cholangitis is a complication for obstruction. So
Impacted
this is
stone.
CBD stone.
Yes.
Complicated or ascending cholangitis. Next.
Can I continue or?
No. Another one.
Okay, me, doctor.
يلا جو اون. دكتور هيفا انت الاخيره، انا سمعت صوتك. اوكي يو ار ذا لاست وان. اوكي ما هم اغلبيه، اعمل ايه طيب؟ يلا جو اون يا دكتور. يلا جو اون.
60 years old woman presented with 6-month history of itching. He has recently noted her urine become dark. She has no pain, but on examination is mildly jaundice. I think primary biliary cirrhosis.
Yes.
Primary biliary cirrhosis. Female.
Because female.
42.
Yes.
Long history.
Itching. Jaundice. Why jaundice? As we said, the autoantibodies will attack the liver
structures of hepatic
and biliary tree will lead to intra and extra, intra only, and these cells will be attacked, then leaking of the bile will lead to cirrhosis. So it is simple. Bile tubes, the stones forming the bile tubes will be destructed, then the bile will escape to the liver, leads to biliary cirrhosis. Okay. Plus obstruction because of the strictures, then it is obstructive or mild and mixed hepatic and post-hepatic jaundice. Next one.
Diarrhea, diabetes.
Anyone? دكتور هيفا. دكتور هيفا يلا go on the last one.
Can be started, doctor. Okay.
Okay. يلا دكتور.
يلا 52 years old. Reformed alcoholic who was attend the hospital frequently with abdominal pain, present with weight loss, diarrhea, and he is diabetic. Can I see the option again? Yeah. Hepatocellular carcinoma or
Number D, I think.
It's chronic pancreatitis.
Chronic pancreatitis.
Oh, chronic pancreatitis.
Because attending to hospital frequency with abdominal pain and diabetic. عند الكحوليك.
But there is weight loss also.
Weight loss.
Because chronicity of inflammation.
Okay, actually we have answered this question about 3 times. One is a question posting, one previous
Yes,
lecture,
yes.
and
Yes.
this is April scanned exam, a real exam questions. And the same in April 2018, this is the number of questions. We have here old patient. As we said, alcoholic, so you can say it's cancer. Post-alcoholic cirrhosis, HCC. But this pain will say not cancer. And this weight loss can say cancer or chronic pancreatitis. But diarrhea and diabetes, due to diabetic, due to pancreatic insufficiency, and diarrhea because of absence of lipase. And then you will have steatorrhea to be more specific. So you have here chronic pancreatitis in one hand will give you alcoholism because it is Eastern country like UK. Alcoholism is more common than gallstone pancreatitis. So
I think
you have
Doctor,
alcoholism. Yes.
I think more the K of the question is more common abdominal pain because cancer is no pain.
Yes, let's take it from the start. Alcoholic could be with pancreatitis and attended frequently. So this means that acute attacks. So it's a chronic disease on top of acute. Abdominal pain, so it is inflammation or not cancer. Weight loss with a chronic due to being afraid from eating. Diarrhea and diabetes. Diabetes because the chronic pancreatitis will lead to pancreatic insufficiency. So definitely it is chronic pancreatitis. اوكي، حد مش متفق معاه؟ Anyone from the surgeons? Anyone ready to answer this?
Yes, I'm ready. Can I answer, please?
Yes. Look at the rapid look at the options.
Adhesions, bizarre, chronic malignancy, Crohn's structure, fecal impaction, gallstone ileus, intussusception, paralytic ileus, sigmoid volvulus, strangulated hernia.
You can answer one question and anyone, and each one question. Yalla, go on.
72-year-old man presents with abdominal pain and distension. On examination, the pain is worse in the lower abdomen. An abdominal X-ray shows a single loop of dilated bowel that turns back on itself. I think it's sigmoid volvulus.
Yeah. So you said
sigmoid volvulus.
Volvulus. Next one.
Can I start, Dr. Reda?
Yes, go on.
42-year-old woman present with 24-hour history of central abdominal pain and vomiting. On examination, she had midline laparotomy, scar, but no another abnormality. So this adhesion.
As we said, the most common cause of small bowel obstruction is adhesive cause due to previous surgery or obstructed hernia or tumor, written like this. But adhesive in IO is the most common. Next one.
Continue.
No. حد حابب Anyone like to start with us? Dr. Jihad, Dr. McBain, Dr. Shadi, Dr. Sana, please, we are here not to watch. You can watch this lecture recorded, but you have to participate.
Can I answer?
Can be, Doctor.
You, any one of you, and the next one will be the last question.
Presents with a 12-hour history of colic abdominal pain and distension. Abdominal X-ray shows multiple groups of dilating small bowel and gas in the biliary tree. I think it's Elias.
What? Which Elias? Gallstone Elias or paralytic?
Yes, Gallstone Elias. Yes.
Gallstone. Next one. Thank you. Thanks. Next doctor.
Can I answer?
Yes.
Can I answer?
Yes.
A 66-year-old man underwent a semi-elective bowel resection for a cecal tumor 2 days ago. You are called to see him as he is vomiting and has not passed flatus since the operation. On examination, his abdomen is distended but not tender. Paralytic Elias, mostly. Paralytic Elias. Paralytic Elias. Bowel sounds are absent immediately post-operative 2 days only.
And not tenderness.
Abdomen distended, not tender.
انتوا بتجاوبوا ليه عن بعض؟ ما انا سبت يا جدعان انتوا.
انا كنت هجاوب لسه ما خلصت السؤال.
Tried to give him labos.
Paralytic Elias. A 14-year-old girl is brought by her parents to the emergency department with a 12-month history of indigestion, nausea, and stomach. Can I see this word after stomach?
Stomach upset.
And the stomach upsets. She has a history of psychiatric problems for which she is regular follow-up. Abdominal examination is unremarkable. Barium swallow shows an irregular round filling defect. Irregular round filling defect in the duodenum. Stomach. Can I see the answers? Regular round. Foreign body. The answers, please. Can I see the answers?
The answers in front of you. These are the answers.
They are not clear. They are to the right of the screen. But I think foreign body ingestion هو بيزور.
Yes.
I think
okay, now okay, to be trained and to be perfect, no one can open now. Now, anyone has any good idea or any discussion or interaction can tell us.
Yes,
and you can open now.
But the screen was not clear.
Can you explain number 5?
Wasn't in the middle.
Okay, now it's clear.
Yes, the question. I am speaking about the answers.
These are the answers. It is clear for your friends and clear for me from my mobile.
Yeah, maybe you are making Zoom.
Yes. Sorry.
It is clear or not?
Yes, it's clear. Yes.
خلاص يبقى please stop. Now you can. Okay. Number 1.
Yes.
As you see, this is U-shape or coffee ground appearance. So this is sigmoid volvulus. IO due to sigmoid volvulus. This is previous surgery, and as you know, the most common cause of IO, especially small IO is adhesive cause post-surgery. Here is pneumobilia with IO. So this is gallstone ileus. This is a post-operative IO, mostly due to gallstone ileus. Number 5, this is a psychological problem with this adolescent girl. She is eating hair or eating pica, whatever. This hair or this foreign body will be collected as bezoar. Bezoar means foreign. So she eat her hair, okay? I don't know, have you seen a picture of bezoar before?
No.
Yes, I have seen in a practical.
Yes, in practice we see this. I will show you on the group a picture of gastric bezoar.
Dr. Reda, so what's the irregular round filling defect? Is that the foreign body?
Yes, like this. See, this is found in the stomach. She is eating the hair. She is eating strange things. This is a psychological problem. Will lead finally to collection of this hair, which is undigested, and a picture of intestinal obstruction. Is it clear? Okay. So the bezoar is an indigestible mass of material, usually ingested hair or fibers, and found in the stomach or intestine. This is a psychological problem. Next one. The one who will answer, raise your hand. Dr. Widad, then Dr. Asad. Dr. Widad, you can answer the full.
Okay.
Yes.
A 54-year-old man has long-standing hernia above and medial to the pubic tubercle that does not descend into the scrotum. The hernia is easily reducible and patient is asymptomatic. So this is answer is elective repair. This is direct hernia or elective repair, asymptomatic.
Okay. Why you repair hernia? Okay, Nick, I will make this is elective. Okay, I will answer at the end. Then next.
75-year-old woman has hernia in her left groin that is below and lateral to the pubic tubercle. On examination, the hernia is tender, erythematous, and irreducible. And the patient is complaining of colic, abdominal pain, and vomiting. So this is emergency repair. This is obstructed femoral hernia. So emergency repair.
Brilliant. Next one.
74-year-old man has a hernia that above and medial to the pubic tubercle and descend into the scrotum on standing. On examination, the hernia is reducible and the patient is asymptomatic. This is the indirect inguinal hernia. Elective repair. I will see the options, please. Can I see the option? Observation only. This one. Observation only. C.
For number 3.
For number 3, C.
Mm-hmm. Okay, next.
A 62-year-old woman has hernia that is below and lateral to the pubic tubercle. On examination, the patient is well and the hernia is painless but irreducible. So this is incarcerated hernia and this is elective repair.
Elective.
Show me the options. This cheap.
Okay. Elective, emergent, observation, prompt or urgent?
Prompt repair.
Okay.
Prompt repair.
Sorry, what's mean prompt repair?
I will show you after we finish. We will show together. Number 5.
57-year-old woman, man has scrotal hernia that has only been present for fortnight. On examination, the hernia is irreducible but painless. Fortnight. So, you'll see the options, please. Urgent repair, this one. Urgent repair.
Despite or although these questions are not important for MRCS, but I will give you a rapid hint, okay? Elective repair for reducible, indirect, or symptomatic direct hernia. Okay, this means elective repair. Prompt repair, irreducible, indirect, or hernia diagnosis less than 4 weeks. Because the greatest risk of strangulation in the first 19 days. Urgent repair for femoral hernias. Because the risk of strangulation during the first month. So this is urgent. Emergent repair due to painful, irreducible hernia. So we will come back to, again, you can answer it in another way. This man with a small direct inguinal hernia, small and direct. So asymptomatic and the patient has no problem and it is small, then
So observation.
Observe only. This one is female with femoral hernia below and lateral to the pubic tubercle, so it is femoral. But now it is tender, erythematous, and irreducible, so it is going to be strangulated. Okay?
Emergency repair.
So this is going to be emergency. Number 3, you have reducible indirect hernia. As we said, this is indirect one, not direct. You cannot leave it. So as it indirect, I know it's asymptomatic, but it's supposed to be repaired via elective repair. So the option 1 is direct and small, so leave it. But number 3, it is indirect, should be repaired via elective repair. According to the hospital policy and the School of Surgeons, you can be different here. Okay, regarding the prompt and the elective. So I don't suppose to answer this question. No, this is, yes. This easy one, okay. This is femoral hernia and the hernia is painless but irreducible. So the difference between emergency repair in number 2 to this femoral hernia, because it is irreducible, so it's going to be emergent one. But here is urgent. Urgent, I don't know how to make it easy for you, like urgent versus emergent.
Urgent means more faster. Yes?
No.
Emergency within 6 hours.
Anyone
Urgent,
has any idea?
emergency within 6 hours. The intervention should be within 6 hours. Urgent, I think, up to 24 hours.
Anyone can tell us that emergent, this one is urgent or emergent? Emergency or urgency?
Urgent.
Okay, so let's conclude that this is urgent. Why? Because emergency means hours, but urgency means days. I know the regulation of NCPOD, and I know that even up to date 2020 has no clear definition between emergent and urgent. Some says 1 to 3 days is urgent, and emergency means less than 4 hours or 8 hours. So we cannot make it precise. The thing is, I need you to know, just to know, immediate, emergent, urgent, lastly elective. Between them, there is expedited surgery, but this one is emergent because situation like needs to be within less than 1 day. But urgent surgery situation where the condition can be dealt with the next day after resuscitation, so until days. So this one can be postponed to tomorrow, but emergent one in number 2 couldn't. It is a general idea, I know, but it's not for you to understand or to know the clear definition of emergency versus.
I think it is depend on the stability of the patient. Yes, Dr. Reda?
Yes, of course. But again, it is according to the NCPOD, okay? I posted to the group to understand that no clear definition, like immediate means immediate A or B, life-saving or organ-saving. Urgent means within hours.
I have some information, Dr. Reda.
Yes, of course.
Urgent surgery is one that can wait until the patient medically stable, but within 2 days. Emergency surgery is one that must be performed without delay.
But when exactly? At the point, I know this is NCPOD. Immediate means that the resuscitation should go in theater concurrently with the surgery. But urgent, you can manage the patient within hours to 1 day until you stabilize the patient. But
So,
when no clear margin.
Urgent within 2 days. But emergency, you have to take the patient to prevent like death or avoid disability.
Okay, very nice. Okay, next question. Incisions.
Can I answer, Dr. Reda?
Yes, go on.
A 15-year-old girl presents with a central abdominal pain that localizes to the right iliac fossa. She also complains of a loss of appetite over the last 24 hours and nausea. On examination, she has a temperature of 37.8 and a standard in the right iliac fossa. Lens incision.
Very good.
Continue.
Next. Yes, continue.
A 40-year-old woman is undergoing elective cesarean section for a breech presentation. Can I see the answers, please?
Still
C-section.
still incision.
Finished steel incision, yes.
Finished
steel incision.
Incision. Next.
A 42-year-old man with non-peptic ulcer disease presents with sudden onset severe epigastric pain. On examination, he has a tender rigid abdomen and bowel sounds are absent. Midline, but can I see the answers? Upper midline, can I see the answers for sure?
It's perforated peptic ulcer.
Midline laparotomy. Midline laparotomy.
Okay.
A 34-year-old woman is undergoing a laparoscopic cholecystectomy. Unfortunately, the surgeons are unable to clear the anatomy of the area due to the presence of adhesions. Kocher, can I see the answers? This Kocher incision? Can I see the answers?
Yes, of course.
This Kocher incision, if it is present. Kocher incision, yes, right subcostal incision.
Last one.
A 64-year-old woman is about to undergo a Whipple procedure for pancreatic adenocarcinoma. It is can I think Mercedes incision if it is present. Can I see the answers?
Okay.
Patel incision?
No.
Great iron incision, Kocher. That's no great iron for appendectomy. Maybe bilateral Kocher incision. Kocher incision.
It is a rooftop. Okay, it is not important. The last one, it is a rooftop incision. So
Yeah.
lens for appendectomy in female, and now it's not preferred option. They already prefer McBurney. Finished heel C-section, midline laparotomy for exploration, Kocher's incision for open cholecystectomy, and rooftop like this, okay, under the costal margin and open both. It is
Bilateral
a bilateral Kocher's. Yes. Again, regarding the last question of emergency versus, I know many are sending me a picture. I have the same pictures, but no clear margin. The idea of NC-BOD is immediate, emergency, urgency, and elective. Okay, so according to the resuscitation timing, and the question was in MRCS, and it's about immediate A, life-saving, or B, limb or organ saving, so you have to do it immediate. Resuscitation can be done in theater. No time for resuscitate the patient. Urgent means within hours, 2 days, and you can go for it tomorrow until stabilizing the patient. Like compound fracture, perforated bowel, peritonitis, so it can be delayed until 24 hours. Expedited within days of decision to operate, like tendon repair, nerve injury, and elective, it is you are planning to make it within weeks. For example, like elective cholecystectomy and all of this. Okay, so it is about the timing. No clear margin about the timing. It's not about the timing at all. Okay, next one, Dr. Asad.
Okay, doctor, can you hear me?
Yes.
Okay.
You have all of this.
Okay. 76-year-old woman is admitted to the emergency department with a history of abdominal pain, passing blood per rectum, and hematemesis. Okay. An urgent upper and lower gastrointestinal colonoscopy are performed, but no active bleeding can be noted. The patient is showing signs of hypovolemic shock and is still passing myeloma. Her hemoglobin drops to 4 over the space of 4 hours. Maybe duodenal ulcer?
Upper and lower normal.
You have to choose from here. So diagnose and choose the investigation of GIT bleeding.
Okay, OGD for diagnose maybe? You try with OGD.
Angiography.
Okay, next. Again, like Dr. McBain said, we will talk at the end. He said OGD. Next.
No.
Yes, Dr. Asad.
Okay, so OGD for diagnosis, maybe upper GI bleeding.
Oh, no problem. Next one. We will discuss
Okay.
after we end.
Okay. 63-year-old woman present with hematemesis. After initial management, she was sent for an upper GI endoscopy. The endoscopy sees a bleeding gastric ulcer with a vessel at the base. Can I just see the answer? Maybe adrenaline injection if it's the management.
Okay, so adrenaline.
67-year-old woman present with a fresh rectal bleeding. She also admits to a history of left side abdominal pain that is relieved by passing stools. Examination is unremarkable, and the patient is hemodynamically stable. Maybe diverticulitis, diverticular disease, or
Diverticular.
or maybe cancer of the cecum.
So you have here no CT, and you have colonoscopy.
So colonoscopy, I think, yeah. We should go for colonoscopy for diagnosis.
Very good. Next one.
Okay, a 42-year-old man present with fresh blood loss per rectum. There is no hematemesis or melena. He has no history of similar problems. On examination, his pulse is 138 and blood pressure is 80/42. Maybe proctosigmoidoscopy. Okay, yeah, he has low blood pressure. Maybe can I just see the answers? I think maybe. He's urgent laparotomy, I think. 45-year-old woman present with 4-week history of passing blood per rectum. She complains of seeing small amounts of bright red blood on the toilet paper and in the pan. The patient is otherwise well. Can I see the answer or not? Yeah, for diagnosis, sigmoidoscopy.
After we finish, you will intervene. Last one, you said procto.
But I think it's anal fissure, or it might need sclerotherapy for maybe for management.
Where is the pain? Where is the post-defecation pain? There is no pain, so it's not fissure.
Okay,
let's conclude.
Internal hemorrhoid, I think.
Yes, so proctosigmoidectomy. Let's conclude from the beginning. First is continuous melena, and you know it is a hypovolemic shock. Okay, so how to prevent this lower GI bleeding? If we have both upper and lower endoscopies are negative, then you will interfere with angiography. Okay, so number one is not OGD. You will go for angio because angio is also therapeutic. You will stabilize him and you will go for angiography. Okay, no problem. Stabilization, and number one, you will go for ABCDE and stabilize the patient, and will go for angiography to inject or embolize the bleeding vessel. I will show you a picture in up-to-date 2020. It is made very easy, but don't go through deeply in it because the picture will go to a further MR enterography and many investigations that's not required for MRCS, okay, for upper and lower GI bleeding. Okay, so here already done upper and lower GI. The next is to do angio. Okay, number two, it is just a treatment, a bleeding ulcer, and why exploration? He need, like in the answer, it is adrenaline injection. Okay, she is sent for upper gastrointestinal endoscopy, and the endoscopist sees a bleeding gastric ulcer. At the same time, he will inject it in this step with adrenaline. Okay. Number three, suspected diverticulum, then CT colonography or colonoscopy. CT colonography, you will inject a dye and you will do CT. But
sorry,
this is
doctor.
not. Yes.
Question number 3. If not giving a colonoscope, the answer is CT.
Yes, of course, because the gold standard.
Initial.
Yes, initial, and it is only no rule for ultrasound in suspected diverticular disease. So you will do CT versus colonoscopy.
CT with IV contrast.
Yes. Okay. Number 4, as we said, in upper GI bleeding or lower GI bleeding, you will start with OGD. Okay. So number 1, as you have still a suspected upper GI cause, you will go for OGD first. Yes, it is lower, but you will start with OGD to rule out upper GI cause. Then you will go for lower GI colonoscopy. Okay.
After stabilization of the patient,
Of
right?
course, of course, he needs investigation, not the initial step.
Yes. I just.
Of course. Yes, brilliant. Very good. Number 5, it's not fissure. You have no post-defecation pain. It's just hemorrhoids, and the good investigation for hemorrhoids is in clinic or inpatient proctosigmoidoscopy. Okay. Anyone has a problem in these investigations?
About question 2, please.
The man holding the endoscopy found a bleeding gastric ulcer with a vessel at the base, maybe splenic artery or Delafoy lesion, AV malformation. So he just need initial intervention in the OGD. What he will do? Adrenaline injection. It's written like that. Yes, sorry?
Yes.
That's all. Okay, for upper GI, I will send the picture from up to date 2020, but please don't go for further. Like you will find capsule enterography and many investigations not needed for me or for you.
So, Dr. Reda, when we will go for urgent laparotomy?
If you have a clear diagnosis and you have a pre-interventional investigation done. Of course, I know you will go for laparotomy, but how you will go for laparotomy and you don't know where exactly the cause. I know in MRCS you have a questions like that, but look again to the questions, you will find you have found a clue why you will open the tummy of the patient and you don't know where are you going. Again,
I think seeing a vessel at the base, it's an indication for.
I will show you the picture again. It's after you find. I know a patient in a hospital in Egypt. They have done until MRI enterography and no cause. Okay.
Yes.
So you will open the patient's abdomen when you know where you are going to treat. Like angiography may be treating the patient, even if the patient is unstable. But they are talking about a bleeding aortic aneurysm, AAA, rupture, and the patient is unstable. So you will do CT or open the tummy of the patient. You will open the patient because the patient is unstable, no time for CT. This is the types of question I know you are thinking about, but not the case. Again, to be conclusive, if you have lower GI bleeding, you will see if you have a clue for upper GI cause, then you will do OGD. If you have no for upper GI cause and you already excluded these causes, you will do colonoscopy, then angiography. Okay. Types of hernias. Anyone can answer?
Can I answer?
Yes, can I?
Yes, Doctor.
Can I read?
Number 5, someone is asking me privately about proctosigmoidoscopy. Again, for hemorrhoids, again, I will go again for the question. 4-week history of passing blood per rectum and small amounts of bright red blood on the toilet paper. So it is not like a fresh bleeding per rectum, larger amounts. So I know it's not clear that this is hemorrhoids, but he needs you to think step by step like a ladder. So you will think in a localized cushion or localized hemorrhoids, so you will do proctosigmoidoscopy. Yes, this will be in your mind. It's not necessary for us as surgeons that we will going to do proctosigmoidoscopy without anything. This is for you to know, just to be with mind thinking in a step-by-step approach. So the least one to insert in the patient is proctosigmoidoscopy. Okay, types of hernias.
Yes.
Dr.
Can I
Reda?
read the please?
Yes.
Would I answer?
The first
Hello?
one. Yes.
Yes.
Yes, you and then doctor, the female doctor. I don't know what's your name.
Sabah.
Yes, Dr. Sabah. The doctor and then Dr. Sabah. يلا يا دكتور.
Me?
Yes, you.
Yes. 63. Please. 63 years old man presented with lump in his groin. On examination, there is mass in the scrotum, which should not disappear on lying down. There is no pain or erythema associated with the lump, and patient is asymptomatic. When the patient cough, and pulse can be felt over the hernia. Please, can I see the answer?
Reducible inguinal.
Reducible.
What is reducible?
Inguinal hernia.
Inguinal hernia, yes. Reducible
Okay.
inguinal hernia.
Indirect.
Okay, inguinal hernia.
Indirect
So
inguinal.
it is reducible. Next one.
Okay. 34.
هو
34-year-old man.
he will complete
Ah,
and
okay.
you are the next, the full
Okay,
scenario.
sorry.
The next, no problem at all.
Okay,
Sorry,
okay.
sorry.
34 years old woman presents with lump in lower midline in his abdomen. On examination, you note that the lump in the lower end of midline laparotomy scar. Lump is 4 centimeter in size, and the content cannot be returned to the abdomen by pressure. There is no cough impulse. The lump is felt is either neither painful nor erythematous. Can I see the answer, please? This is slide. Sliding. Cannot be returned. This is reduced, strangulated. Strangulated? Incarcerated, okay.
Incarcerated.
Incarcerated,
Incarcerated.
Yes.
Incarcerated.
Okay, next one.
48 years old woman present with a small lump in groin below lateral pubic tubercle. She also complained of vomiting, colic abdominal pain. On examination, the lump is 1 centimeter in diameter and painful and erythematous. No cough and pulse. This is femoral. But can I see the answer, please? This is strangulated now, I think.
Yes. Okay. Next.
45 years old woman, man who has non-direct inguinal hernia presented to the emergency department as his hernia has become painful over the last few hours. On examination, hernia is irreducible, tender, erythematous. The patient denies any colic abdominal pain, vomiting, or constipation.
Obstructive.
Answer, please.
Obstructive.
Obstructed. This is. Obstructive, this is on.
Read it again. It's number 4.
Yes. 45. No, directing wine hernia. Or an examination hernia is reducible. Tender erythematous.
Strangulated.
Strangulated?
No, this is richer, Dr. Reda, richer hernia.
Exactly.
Richter
or Richter's hernia.
Richer, because no obstruction.
Exactly. I will tell you why it's Richter, but after we finish.
Okay.
Next.
78 years old woman present with a previous epigastric hernia, presented severe abdominal pain and vomiting. On examination, she is pyrexia, tachycardia, and has a diffusely painful, rigid abdomen. No bowel sound can be heard. Her hernia noted erythematous and irreducible. This is obstructed, I think. Huh?
It's perforated.
Yes, rigid abdomen. Yes, sorry. Pyrexia and rigid abdomen. This.
So last answer.
Perforated. Pyrexia and rigid abdomen. No bowel sound. This is perforated. Yes.
It is perforated. Okay.
Yes.
Okay, I will give you a conclusion here. The normal hernia is reducible, can go back to the tummy and gives expansile impulse on cuff. Irreducible or incarcerated hernia due to adhesions will give no impulse on cuff or little impulse on cuff and cannot be returned back to the tummy. Obstructed, it is incarcerated, okay, but with intestinal obstruction. You will find vomiting and you have intestinal obstruction. So reducible, irreducible, or incarcerated, and here is obstructed one. But if you have part of the lumen of the intestine, like here, with cut of blood supply, so you have strangulated Richter's hernia, but the lumen is okay. No vomiting, no intestinal obstruction, so it is Richter's or Richter's hernia. It is strangulated or obstructed, or incarcerated, means irreducible, but with no intestinal obstruction. So it is Richter's hernia. Only part of the lumen encountered as a hernial content. Okay. When you have the same picture of strangulation, then you will find instability, fever, vomiting, diarrhea, and everything of instability because cut of blood supply. You have metabolic acidosis, okay? But when this weak wall going to be perforated, you will have peritonism. What's peritonism? Guarding, rigidity, severe abdominal pain with tenderness and rebound.
Fever.
With fever, of course, and leukocytosis and everything of peritonism. So reducible, incarcerated. Now the picture is clear. Strangulated and Richter's with perforation or perforated due to peritonitis. Next, Dr. Sabah.
I'm with you.
Yes, go on.
Okay. 62-year-old, but the page is not obvious, Dr. Reda. First question. A 62-year-old man is brought to the emergency department after vomiting large amount of fresh blood. On examination, he is drowsy with the heart rate of 120, blood pressure 92/50, and urgent full blood count show hemoglobin 6.9, platelet 160, MCV 16, and INR 2.3. Okay, would I see the option? Answer option. This is variceal hemorrhage. Okay, hematemesis, massive hematemesis. This is esophageal varices.
Okay, next one.
Okay, massive hematemesis lead to hemorrhagic shock. This is variceal esophageal varices. Next one, 25-year-old man present with 3 episodes of vomiting that contain altered blood. He has recently started a busy job that he finds stressful, and he has not had time to eat well. In addition, he complained of 6 months history of upper abdominal pain that is relieved by eating, for which he takes ibuprofen. Okay, upper abdominal pain relieved by eating. This is duodenal ulcer. Duodenal ulcer. So peptic ulcer is answer.
Next.
19-year-old student present with blood-stain vomiting. He was on pub crawl last night and spent the later hours of the night vomiting and retching over a pocket. This Mallory Wister after alcohol vomiting. Mallory Wister. Blood-stain vomiting is massive hematemesis. It's Mallory Wister, yes.
Okay, next one.
Okay. 83-year-old man attend the emergency department after vomiting a small amount of...
Number 4.
Okay.
4.
Yes. Okay.
Okay. So number 3 is Mallory Wister.
Yes. Next one.
59-year-old man presents vomiting copious amount of fresh blood. On examination, his pulse 138, blood pressure 68/42. BR demonstrate melena and fresh blood apart from an abdominal aortic aneurysm repair last year. This history of AAA repair, this will be fistula, intestinal fistula. No, it is enterointestinal, aortointestinal fistula.
Next.
Okay. Next, 83-year-old attend the emergency department after vomiting a small amount of fresh blood. He complained of 3 months history. It's a question. History of aching pain in his epigastrium and poor appetite, saying he lost over 2 stone. So this is cancer. The patient denied any difficulty swallowing, not esophageal cancer. On examination, you find enlarged supraclavicular, this is stomach, this is Virchow lymph node. Virchow lymph node, this is CA stomach.
Yes.
Okay, brilliant. All answers are correct. Thank you very much. So,
thank you.
Question number 1. You have a picture of emergency hematemesis. Okay. With this picture of anemia and low platelets and MCV and elevated INR, this is a picture of liver disease, which is associated with portal hypertension and الناس اللي بتتنفس في المايك. طب إيه لما تتنفس ابعد. ماشي. طيب يبقى this picture is suggestive of variceal bleeding. Again, it should be a clear picture of portal hypertension, alcohol, any liver cell failure manifestations will be added in your question, like hepatosplenomegaly, ascites, spider nevi. So we are waiting more features of liver disease. Number 2, ulcer relieved by eating with ibuprofen use or analgesia use, and is going to be duodenal, not gastric, because it is relieved by eating. Then it is peptic, because peptic involves duodenal and gastric, like Dr. Sabah said. Here you have alcohol and bloody vomitus. You have 2 cases. Just superficial tear, known as Mallory-Weiss tear, and the patient will be stable, and this is self-limiting condition. And you have esophageal perforation or Borave syndrome. The patient will be unstable because it is a transmural perforation of the esophagus with
Rupture.
mediastinitis. So when you find a patient with alcohol and vomiting of blood, then looks at the stability. If he is stable and this is going to be good, this is Mallory-Weiss superficial tear. But if the patient is unstable and this is very bad and needed surgical or interventional process or any surgery, this is a transmural complete perforation of the esophageal wall, known as esophageal rupture Borave syndrome. The patient will be unstable. Bloody diarrhea after AAA surgery is going to be a fistula between the aorta and the intestine, aorto-enteric fistula. Loss of weight, loss of appetite, constitutional symptoms of malignancy with old age, and supraclavicular, which is mainly left supraclavicular lymph node associated with intra-abdominal malignancies, especially gastric cancer. Thank you, Dr. Sabah. You have done great. Thank you.
Thank you.
I will not go for antibiotic treatment of any condition, because every hospital has its own guidelines. You can solve it and conclude whatever you want. But I want you to understand that ulcerative colitis and the Crohn's disease treated medically. These are medical conditions. And I know you are general surgeons. I'm talking to orthopedic or plastic, because ulcerative colitis and the Crohn's disease, you will start with medical treatment, then you will go for surgery. And this would be more clarified in GIT Part B OSCE lecture. Okay, anyone can go with this type? Dr. Ayman, Dr. Ahmed, Dr. anyone?
Yes, doctor.
Yes, go on.
Can I see the question? 56-year-old woman present with a history of fresh rectal bleeding after defecation. On examination with a proctoscope, hemorrhoids are seen within the anal canal. The patient denies any prolapse of these hemorrhoids. It is anal fissure.
I need your treatment.
We can use dilatism cream.
Hemorrhoid or anal fissure?
So with the proctoscope, hemorrhoid are seen within
Yes.
anal canal.
You can
So
see the
it is
full. This is hemorrhoids. Very nice.
it is
How
hemorrhoid,
we are
yes.
going? There is symptoms or no?
There's fresh bleeding and pain.
Yes, symptomatic.
Surgical hemorrhoidectomy.
Injection sclerotherapy.
Yes, I think it's like we have to do ligation or sclerotherapy.
Yes.
Yeah, sclerotherapy is first line.
Again, like varicose veins, you will go for like fissure, like fistula. It's not fistula, but anal fissure, hemorrhoids, varicose veins. You are going to treat conservative lifestyle, then conservative interventions, not invasive, like injection sclerotherapy, rubber band ligation. Then you will go for surgery in only specific cases. Okay, like thrombosed, prolapsed type 3 or 4 hemorrhoids, then you will go for surgical intervention. Okay, next one.
A 71-year-old woman present with pruritus any. On examination, she has a voice prolapse rectum. Prolapsed, it needs surgery. Can you see the option again? Delirium procedure.
Complete prolapse, yes.
Delirium procedures. Number A.
Okay, I will conclude at the end. Delirium.
A 22-year-old female with a non-inflammatory bowel disease present with a constant discharge from the anus. On examination, two external openings are seen in the posterior margin of the anus, both of which are discharging feculent material. An MRI scan shows a high-lying anal fistula that passes through the puborectalis muscle. Need fistulectomy. To do fistulectomy, or let's say sphincterectomy.
High fistula, ceton.
No.
Ceton insertion, high fistula.
Ceton infection.
Okay,
Ceton
give him
insertion.
answer and then we conclude together. So your final answer?
Ceton, yes, of course.
Yes.
No, because inflammation is not touch.
Ceton, yes.
After inflammation, you can do
It's high
operation.
also. High fistula also.
Can see the option again, Dr. Reda, for the last. Yes, ceton insertion. It is
H.
Proper. Ceton insertion is the proper. The proper option.
Yes, ceton insertion. I believe.
Okay.
Ceton.
Okay, next one.
Yes. A 42-year-old man present with a 2-day history of pain around his anus, difficulty sitting down, and fever. On examination, there is 1 centimeter tender and erythematous lump adjacent to the anal margin. No other abnormality is evident. Incision and drainage. It is anal perianal abscess.
So?
Incision and drainage.
Very good. Okay, next.
A 34-year-old woman present with a 7-day history of severe stinging pain in the anus on defecation and associated with fresh blood on the toilet paper. Examination reveals a tight anal tone and a long skin tag on the posterior margin of the anus. So the
Anal
skin tag
fissure.
is fissure, yes, fissure. We have to do
It's
sphincteroscopy.
sclerotherapy.
No,
No,
dilitazine cream.
no.
Start by cream.
Start
GTN
by
cream.
dilitazine, yes, initially.
GTN cream, yes.
GTN or
Again,
dilitazine.
again. Okay, I will go because I have collection for all of this in the PowerPoint presentation. We'll go for 30 minutes break and we will come back. Okay, so in the first scenario, you have patient with hemorrhoids. How to start with conservative intervention, which is injection sclerotherapy. As we said, grade 3 and grade 4 hemorrhoids will require surgical intervention, not injection. But this one seems to be type 1 or type 2 rectal prolapse, type 1 or type 2 hemorrhoids. Then you can manage it by conservative interventions like injection sclerotherapy. Number 2, we have prolapsed rectum, okay? And we have many operations for prolapsed rectum, but it's not required from you. But the best one is abdominal laparoscopic rectopexy, okay? This is better, okay? I will show you rapid reading. Just rapid, okay? Anal fistula is a complication of perianal abscess. So perianal fistula is a complication of inadequate drainage, chronicity, inadequate treatment of a perianal abscess. How to treat? Either fistulotomy, simply you will lay it open. This is the standard approach. You will just cut along the whole length of the fistula. You will insert a probe and cut. But what will happen if this fistula is going through the levator ani, transsphincteric? Then if you cut the muscle, this is the sphincter of the anus, then you will have an incontinence. How to do it? To insert acetone, okay? So if the fistula passes through a significant part of the anal sphincter, insert acetone. It is a non-absorbable nylon or zinc thread left until fibrosis, and then you can lay it open later on or just keep it to make fibrosis and will heal. In Crohn's disease, you can add antibiotics and immunosuppressants like azathioprine. Okay, simply this is acetone. Okay, it is a non-absorbable thread, will be inserted. As you see, this is a transsphincteric high fistula. So you will not be able to cut through this. So you will insert acetone. Okay, but here it is simple, lay it open. You will insert a probe and you will expect the site of the external, the internal opening by the good Sal's rule, and it will be discussed in 1st of May. Then simply lay it open through the probe like this. This is the standard approach. For rectal prolapse, we have either mucosal prolapse, and the management is reduction enema, digital intervention, whatever this is, you will manage first conservatively. Second line, just injection sclerotherapy for this prolapsed part of mucosa. As we said, grade 3 and grade 4 internal hemorrhoids should be managed by surgical hemorrhoidectomy. For full rectal prolapse, you have to make a surgical intervention. Full means the whole wall of the mucosa is involved, either by abdominal fixation of the rectum known as rectopexy or perineal approaches. Always we prefer the abdominal approaches like laparoscopic rectopexy, okay? And if the patient is old, frail, unstable, or with comorbidities, then these abdominal approaches will not work. You have perineal approaches. Of course, it's the full thickness, but if it's short, you can manage it by excision, Delrom procedure. You will excise the redundant mucosa and then do a primary anastomosis. This is a Delrom procedure. But if this is a long, how you cut all of this long full thickness prolapse? So again, if this long full thickness cannot be treated by abdominal procedures, then you will perform Altemeyer procedure. This Altemeyer is a perineal rectosigmoidectomy. You cannot do this by just plication or just like Delrom. So Altemeyer for long full thickness prolapse that is not that could not be treated by abdominal procedure. Then you will proceed with Altemeyer. Okay, so this one is Seton, abscess, incision, and drainage, and this one is pain, just a fissure. If you have a fissure, you know the sequence of fissure spasm, fissure, pain, spasm. It is a vicious circle. So if you reduce the pain, you will reduce the spasm and you treated the fissure. So you will start by giving analgesics, diltiazem, cream, nitrates, GTN, okay, all of that. So you will start by conservation. And the final treatment, if this will not work, just lateral internal sphincterotomy. You will stop the spasm by cutting part of the internal anal sphincter. Then the fissure will heal because, as we said, the pain will lead to spasm and lead to fissure. First, cancel the pain by GTN or diltiazem. Secondly, if not treated by this, you will perform lateral internal sphincterotomy. Okay, types of hernias. Who are ready?
Would I answer? Yes. I'm ready.
يلا يا دكتورة.
طيب. أميال, gluteal, gluteal, lumbar, midal, obturator, pantaloon, sciatic, sciaticus. Okay, a hernia that has two parts, each either side of the inferior epigastric artery. This is the dual hernia or pantaloon hernia.
Pantaloon hernia.
Yes, hernia.
Very good. Next.
Both sides.
So this is pantaloon.
Hernia. Or dual hernia.
Okay.
Hernia.
Next one.
Okay, hernia that passes through the greater sciatic foramen Greater sciatic foramen is gluteal hernia, and the lesser sciatic foramen is sciatic hernia.
Okay, excellent. Next one.
Okay, hernia that contain a W loop of intestine within its sac. This is the hernia in W, or second name is myedal hernia.
Myedal's hernia.
Myedal
Very
hernia,
good.
yes, or hernia in W.
Very good. Next.
Okay, a hernia that rises from the triangle of the appetite. This lumbar hernia. Okay.
Okay, very good. Next one, number 5.
Okay, hernia that contains the appendix within the sac. This is amyant hernia. Amyant hernia. This is inguinal hernia.
So your final answer?
Amyant hernia.
Amiens hernia.
Yes.
Very good. Okay, so Little's Meckel's. Little's hernia containing Meckel's diverticulum. Myedal's just flap the M, it will be W. It is containing W-shaped loop of bowel like this, okay? Such the arm in the middle of the W, and be compressed and strangulated. This is called myedal's hernia. And in myedal's hernia, you have to know that you can find a strangulation inside. So you have to inspect the whole length of the intestine. Okay, Richter's only one side of the mucosa, so it could be strangulated because of cut of blood supply, but with no intestinal obstruction. Sliding hiatus hernia, okay, just we have here, this is talking about part of hernia sac wall is composed of bowel. So the bowel itself is part of the hernia sac, okay? But sliding hiatus hernia, it is just that you have a gastroesophageal junction displaced or not, because we have two types. We have paraesophageal hernia versus sliding hiatus hernia. It's not important, but just to know, it is this sliding hernia. It's not for the sliding hiatus hernia of the esophagus, because we have paraesophageal sliding hiatus hernia and its types. Epigastric hernia, you know it. It is in the epigastrium. Incisional over surgery. Spigelian hernia, it is protrusion of the hernia sac through the linea semilunaris, and this is discussed in abdomen lecture. Okay, umbilical hernia, I will leave the notes for you to read. Gastroschisis versus exomphalus and exomphalus major and minor. Okay. Also, very important to know the Bogdalic Morgagni hernia, and this every exam, like a embryological or a embryological condition, will be in your exam. So don't leave it. A pantalon hernia, simply it is a mixed direct and indirect hernia, because it will be a hernia like this, okay, between it's dual, like the doctor said. It is direct and indirect. Why? Because as we said, direct will be medial in the Hasselbach triangle to the inferoepigastric artery, okay, and this is direct, and the indirect will be lateral to inferoepigastric artery. But when you have a hernia suspended in the artery like this is named as pantalon hernia or dual direct versus indirect. Appendix myoidals and lumbar in the lumbar triangle. You have also obturator and many rare types of hernia, but not needed for us. I think this will be more important question. Next. Doctor.
Yes, doctor.
Yes, okay, go on.
A term baby is born with large amount of visible intestine emerging from of his abdomen. The external gut is covered with thin membrane. It is gastroschisis or exophthalmos, yes.
Tick.
Okay, he will answer and then we can conclude.
Okay, number 2. A 34-year-old man present with a lower midline mass that is 8 centimeter in size. He has a history of an emergency laparotomy for toxic megacolon secondary to ulcerative colitis. On examination, the
you
mass
answer yourself, and then after we will decide.
Okay. On examination, the mass is soft, non-tender, and reducible.
Incisional.
لا يا دكتورة, please. Sorry. We will conclude after he decide. He has his time to think.
Yes.
No problem. Okay, next. So this is incisional, like you said. Okay.
Okay. A 64-year-old man present with 2 groin lump, one on each side. On examination, the lump have cuff impulse and are reducible but not extend into the scrotum. Inguinal hernia, bilateral inguinal hernia.
Direct or indirect?
It is direct.
Why?
Because cuff impulse. Not extended to the scrotum.
طب أنا مش عارف اللي بيتكلم. Okay, don't talk again. Okay, yes, you help him, but he has his time to think. Okay.
Okay.
Next one.
Number 4. A 42-year-old woman present to the emergency department with colic abdominal pain and an abdominal lump. On examination, the lump is in the midline, just above the umbilicus, and is tender to touch. It is para-umbilical. I can see the option. It's
yes, of course.
Yes, but I'm like he doesn't mean he want strangulated or not. It's like
okay, we will discuss later. Next.
Number 5. A 39-year-old man present to the emergency department with a tearing pain in his upper abdominal after trying to lift weight at home. On examination, you find a 2 centimeter lump at the site of the pain in the midline of the abdomen, halfway between the sternum and umbilical. It is epigastric. Epigastric hernia.
Okay, epigastric. Again, the same PDF. I know till now you have questions in hernia and not answer correctly. If you will read this made in pictures, like yellow one is a fascia transversalis, the red one is external oblique aponeurosis, and the green is superficial, and this violet is deep ring. So this is the inguinal canal, connects the superficial and deep ring, and this is the site of deep ring, just half an inch above the midpoint of inguinal ligament, because it is an inguinal component, not like the artery. It is mid-inguinal point. What is the difference?
Yes, doctor. Difference.
The MIP is from here to symphysis in the artery, for the artery. Okay, so mid-inguinal point is the part from anterior superior spine till pubis symphysis. This is mid-inguinal point for artery. But here, from the pubic tubercle to the anterior superior spine, for the deep inguinal ring. Midpoint of inguinal ligament for this component, okay? What is the boundaries of the inguinal canal? Make it simple as it's the picture. Posterior wall, it is here, fascia transversalis. Anterior wall, you will find the external oblique aponeurosis like this, because already the triangular slit is just an opening or a defect in the external oblique aponeurosis. So this is the anterior wall. The floor is inguinal ligament, and roof is the arching fibers of transversus abdominis and internal oblique. So if you read this, you will never have an answer correct wrong, even in types of hernia, exomphalus major and minor, 4 or 5 centimeter exomphalus minor, more than 5 centimeter or 5 centimeters exomphalus major. But what is the main difference between gastroschisis and exomphalus, or the same name as omphalocele? Gastroschisis is an isolated abnormality. The bowel lies outside the abdominal wall through a defect located at the right side of the umbilicus and not covered by anything. So no peritoneal coverage, no seal. But omphalocele or exomphalus, both types, have seal, have cover. So it is liver and gut covered by peritoneum, okay, which is a membranous sac, and connected to the umbilical cord, okay?
For gastroschisis means it's emergency operation, I think.
Of course. Yes. What is the more severe, as we said in the question posting many times, okay, but what else asked? Yes, direct versus indirect. I know these questions are not of vital importance, but you have to know it because the anatomy. So this is the rectus muscle, lateral margin, and this is inferior epigastric artery, and this is inguinal ligament. This is known as Hasselbach triangle. Any swelling here, any protrusion, this is direct inguinal hernia. This hernia could not reach the scrotum, but if you have a defect in this canal, a defect in the fascia transversalis here, you will find oblique indirect hernia that can reach with the scrotum. Why? Because already this defect made by the spermatic cord that is dragged down from the back till reaching via the gubernaculum to the testis. So you have a question as gubernaculum. You have a question that a hernia that can reach the scrotum. This is indirect or oblique inguinal hernia.
inguinal hernia.
يلا اللي بعده. This is very important. يلا.
يمكن أجاوب.
دكتور ميوكند، دكتور علي هادي، ميوكند، دكتور الطيب. Any doctor can answer. دكتور أسعد. Okay, anyone hasn't answered yet? دكتور ليزا، دكتور عدي، دكتور شاهينين، دكتور شادي. Please raise your hand and participate. Okay,
Yes,
anyone can answer?
Yes, can I?
Yes.
Yes, can I?
The priority for the people who has not answered. Anyone has not answered yet and want to proceed before I go for the people who already answered?
Sarah can read if you want.
So Dr. Asad,
Okay,
this is the first one for you.
No, this is the second time. I read before.
Okay. Dr. Uday?
Yeah. A 62-year-old man presents.
And sorry معلش عشان الدكتور ما يزعلش، اللي كنت بكلمه الأول مين اللي كنت بكلمه؟ دكتور الطيب ولا مين؟
Yes, دكتور.
Yes، أنت اللي كنت بتكلمني قبل دكتور عدي صح؟
بعتقد ممكن.
اللي قال دي second time.
Sorry?
Not me. I think someone said the second time. I don't know what's the name.
دكتور أيوة موجود أنا دكتور. أقرأ يعني؟
Yes, دكتور أسعد. Go on and then دكتور عدي. يلا.
طيب. 62-year-old man present with 2-month history of pruritus ani and occasional fresh blood on the toilet paper. He denies pain on defecation. On examination, there is evidence of ulceration of the anal margin.
He answer and then we talk.
This is anal fissure. Sir, should I find diagnosis?
Okay,
or
you said anal fissure. Is that final?
Pain and fresh blood.
No pain on defecation, so not fissure.
Dr. Asibi, please let him think. His question.
I think maybe Fogax, or can I see the answer?
Okay, you can see and then collect answer one answer.
Maybe proctalgia Fogax.
So you said proctalgia Fogax. Okay. I'm not angry about someone want to answer Dr. Sabah, but I want to show for himself his actual hesitations inside his exam. So he will get benefit that I have to determine what to select. Then the answer will be known. It's right down in the same PDF. Yalla. You said proctalgia Fogax, right? Okay.
Yes. Okay, a 28-year-old man present with a long history of intermittent pain in the rectum. The pain tends to occur at night. He denies passing any blood or mucus per rectum. Examinations are remarkable. Okay, the second one is proctalgia Fogax, I think. I'm sure about this one. The first one, maybe I will switch the answer after I look at the options again.
Okay.
Maybe the first one.
Rectal prolapse.
لا يا دكتورنا Dr.
Cancer.
Uday, you are the next full scenario.
Okay, so I'm gonna go with rectal prolapse.
Rectal prolapse.
Yes.
Anal cancer. Anal ulcer.
There's ulceration at the anal margin. Yeah. So ulceration may be cancer.
طب
Yes.
اوكي
Maybe cancer as well.
دكتور اسم
But,
حضرتك ايه؟ انا هاخد اسمك بس.
I will leave it indefinite. عبد الفتاح معك دكتور.
اسم دكتور اسعد. طيب اوكي. انا هفتح له هو المايك عشان ايه اللي هيفتح خلاص. انا ليه؟ انا عندي الكنترول اهو. دكتورة فاطمة، دكتورة صباح، ودكتور عدي، تقدروا تعملوا كورس مع بعض. It will be very nice. Okay. So number, I forget where are you? So this one, Dr. Asad, final answer.
I think he's gone.
He's gone.
Can I proceed?
Dr. Asad?
Hello?
Dr. Asad, yes.
Yeah, number two, proctalgia fogax. I'm sure.
Okay,
Maybe that's my answer for number two. Number three,
fugax. Okay,
yes.
next one.
46-year-old woman complains of stinging pain that occurs on defecation. This has been occurring for over a month. Rectal examination is very painful and there's skin tag at the anal verge. Because this is anal fissure.
Brilliant. Thank you.
Thank you.
Next.
39-year-old woman presents with sudden onset anal pain that occurs while standing at the toilet. On examination, a smooth dark lump can be seen at the anal verge. This is a hemorrhoid, third stage.
No. I couldn't leave you in this
No
one.
problem. It's okay. It's okay. An examination is smooth. Okay, maybe anal cancer. If it's not hemorrhoid, then it has to be cancer.
Perennial hematoma.
Maybe hematoma.
Perennial hematoma.
Prolapse.
Okay.
Thrombospine.
بتخلص على خير.
Okay, a 32-year-old man presents with a long history of pruritus NI. On examination, large pink confluent lesions are seen around the anus. Okay, this is cancer. Anal cancer, the last one.
But large pink
confluent
lesion.
Anal wart. Genital wart.
Okay, can I see the options? Maybe if it's in the options. Warts are not
condylomata.
Condylomata acuminata. Wart. Genital wart.
Okay, D. Initially, I'm going for cancer, but I'm going with D now.
Why cancer?
Because of the shape of the bulge and the color. I thought maybe it's an outgrowth. Maybe late stage.
Okay. Has you done? I will leave Dr. Sabah to tell us number 1 to 5, her answers and her explanations. I will give her the chance.
Okay.
Okay.
No problem.
Okay. Number one, because of the last line, there is evidence of ulceration of the anal margin. This is the anal cancer. According to the age and the history of pruritus NI and the ulceration at the anal margin, this is the anal ulcer. Number 2, according to age, 28, anal cancer. Yes,
okay.
Number 1. Okay. Number 2, according to the age, young age, and intermittent pain in rectum, and examination unremarkable. This is proctalgia buccax. Number 3.
Okay, number 3.
Okay, number 3, it's very obvious because the stinging pain, this anal fissure. Rectal examination, very painful, this anal fissure.
Skin target.
Number 4, on examination, a smooth dark lump. This thrombosed bile or perianal hematoma. This for urgent surgery or hematoma evacuation. Number 5, number 5, large pink confluent lesion around the anus. This anal wart, genital wart, or condylomata acuminata, not lata. acuminata.
مين بقى ادى حضرتك الاي فايلز؟ ما هو definitely انا سمعت محاضرة الدكتور صلاح المرة اللي فاتت and he told how you at the same timing I thought the same thoughts how you got I'm sure
الاكسبلانيشن اغلبها قريبه متشابهه من الاي ام ار سي اس والجزء منها في الباست تست. دكتور رضا.
Do you agree with her?
دكتور رضا لو سمحت.
I think Dr. Salah is Dr. Salah is extensive reader.
No, because he told why you know the answers by yourself and even any surgeon will got some mistakes.
Usually the answer, I think, in any MCQs, it will be in the last line and first line. Usually,
Like
this is my way of solving question.
The previous one, like it is hemorrhagic shock in the same word written in the explanations.
Because it is hemorrhagic shock.
Okay. So,
Dr. Reda, please.
Yes, of course.
The number 4. Why didn't rectal prolapse, please?
Pain.
Rectal prolapse. Okay, this is a question of a previous exam, January 2020. Okay, the same scenario, sudden onset pain that occur while straining or lifting heavy objects. It could not be hemorrhoids. Why? Because he will tell you that this patient has previously a lump or mass, because even thrombosis in the hemorrhoids, he should tell us a previous history of a mass or a collection of veins or a cherry red mass or whatever, then a sudden pain. This is thrombosed hemorrhoids. But this one, sudden in nature, okay, with a straining or heavy lifting, this is rectal, this is anal hematoma. Okay, why not? You are not
yes,
you are asking why not prolapse or why not fissure?
Why not prolapse?
No pain.
Where is the prolapse? You have anal pain, sudden. I know you are thinking about a smooth dark lump, but associated with severe sudden onset pain. Why? So if you have a prolapse, the prolapse is having types. Type is managed by manual repositioning. So this will a case of that, a mass and reducible with no pain. But if you have already a mass and strangulated, a prolapsed strangulation or strangulated prolapse, then already there will be a mass. So this is not prolapse, sudden onset anal pain with a smooth dark lump. Prolapse is two types. Prolapse that can be manually reduced, and prolapse that is simultaneously reduced or spontaneously reduced and a prolapse that is strangulated, but this is not the case. If you have a strangulated prolapse here, you can select it. But we have the more relevant option for the scenario is a perianal hematoma, and don't forget, this will be a sudden onset pain due to heavy weightlifting or straining or playing aggressive sport. This is a hematoma that could be ruptured. Okay, are you
Okay.
convinced with that?
Yes, yes. Thanks.
Okay, I think Dr. Sabah has done great. Dr. Sabah, you are done
thank you.
great. Okay, and here, as you know, it is a large bank
Thank you.
with this age, so it is not an age of cancer. And this confluent lesion is known as condyloma acuminatum or a genital wart.
بروكتالجيا فوجاكس يعني إيه يا دكتور؟
Pain.
ولا بعد إيه؟
Fugax, like, you know, when you have a transient ischemic attacks, you have like a fugax. So it is a sudden pain. Proctalgia, proctus means rectum or anus, but fugax means fleeting or pain coming and going, like, you know, amaurosis fugax. Okay, if you remember the transient ischemic attacks.
What is condyloma lata?
What? Condyloma acuminatum, it is a genital wart.
The second one, condyloma lata.
السيفاليس
Syphilis, yes.
Syphilis.
Yes, exactly. It is just a lesion like that. Condyloma means collection or, but acuminata means genital warts. Condyloma lata occur in secondary syphilis, and this does not the case.
Okay.
Yeah.
Another thing, Dr. Reda, also condylomata lata is painless, unlike condylomata acuminata. There is pruritus over the wart.
Yes, excellent. We have discussed this in question posting. Yes, very good. Next one, Dr. Uday. Yalla, go on.
Yeah. A 57-year-old woman presents to emergency department with a tender erythematous swelling in the left groin. On examination, you find an irreducible hard lump below the pubic tubercle. It is a femoral hernia.
Okay, femoral hernia. Next one.
A 24-year-old man presents with groin swelling that descends into the scrotum on standing. On examination, the swelling does not trans-illuminate and you can get above it, but it is reducible. You cannot get above it. I think it's a congenital problem. Inguinal hernia, direct one. Indirect inguinal hernia.
Okay.
Yeah. Third one, a 48-year-old woman presents with 6 months history of heartburn and night cough. She denies any other symptoms. On examination, you note that she is obese, but no other abnormality is evident. Is this reflux disease? Can I see the options?
Epigastric hernia.
Yeah, epigastric hernia maybe.
He will think and to know his full evaluation. So it is epigastric hernia. Next one. After we finish, I will not talk. I will leave you talk. Okay, next one.
Yeah, a 64-year-old man who has history of a laparotomy following a perforated peptic ulcer presents with a tender mass underlying the caudal end of his midline. Can I just see the line? Caudal end. I cannot see the lower line. Yeah. Caudal end of the midline scar. I think it would be an incisional hernia. Operation. Midline scar.
Final answer.
Can I see the options, please, once? Michael's.
Of course.
Is it the Litter's hernia H?
H.
Yeah.
Letters. Is it containing Michael's? Is it?
It is 4 number, yeah. At operation hernia size, yes, it is
letters.
Michael's divertical. Yeah.
Okay. Next one.
A 52-year-old man presents with a lump in his abdomen that is associated with dull ache. On examination, the lump is 2 centimeters in size and below the umbilicus. It is located lateral to the rectus. It's a Spigelian hernia.
Okay, very nice. So easy, as he said, femoral, below and lateral to the pubic tubercle, surrounded by the vein, then the artery, then the nerve. Okay, don't forget these notes. Also, you have the femoral hernia in. We have indirect inguinal hernia. As we said, it is through the inguinal canal itself, can go for the scrotum, and it is in the fascia transversalis defect and medial to the inferior-epigastric artery. Hiatus hernia, protrusion of the upper part of the stomach, and we have many types. Sliding, which is the most common, 95%, and the gastroesophageal junction is pulled up into the thorax. But we have rolling hernia where the gastroesophageal junction will remain in place, like this. So this is moved already, so it is a sliding. But rolling, you have like this. The thoracic cavity containing content, but the gastroesophageal junction is remaining in position. So we have also types of this, mixed and many types, but not important. Meckel's letters, Spigelian, linea semilunaris. What is linea semilunaris? This one. This is the rectus. This is the lateral, the low margin of posterior rectus sheath from behind. This is called arcuate line or linea arcuata. But this lateral margin is known as linea semilunaris. So any part here is its Spigelian hair. Okay. Stoma. It's very easy. Who will go? Dr. Ahmed, Dr. Osama, Dr. Lisa again, Dr. Muhammad al-Rawajdi. You have to participate with us. I need new candidates
60.
or new surgeons. Me.
60. Oh, me, doctor.
Who?
Osama.
Dr. Osama, yalla, go on.
Yeah, 62 years
Read
old.
the options.
Abdominobranchial resection, anterior resection, extended right hemicolectomy, Hartmann procedures, left hemicolectomy, proctocolectomy and ilioanal pouch, right hemicolectomy, sigmoid colectomy, structurouroplasty. Question, please.
Yes.
62 years old woman with no diverticular disease of the sigmoid colon, presented with sudden onset abdominal pain and vomiting. On examination, the abdomen is rigid. The erect chest X-ray confirm air under diaphragm. The procedures is Hartmann procedures.
Yes. Yes. Hartmann.
Hartmann. 64 years old man presented with rectal bleeding and feeling of incomplete empty after defecation. BR after a bare rectum examination reveals a tumor 1 centimeter from the anal margin. 1 cm abdominal brenial resection.
Very good.
Yes,
Abel,
AB resection.
next.
65 years old woman who presented with rectal bleeding is found to have non-obstructed tumor of the sigmoid colon. Rectal bleeding found is non-obstructed. Please give me an option, doctor. Doctor. All right. Anterior resection, I think.
He gave us, is it in the rectum to do anterior resection of the rectum?
No.
Sigmoid.
If sigmoid
area. Hartmann procedure.
is not obstructive.
Okay, I need Dr. Sabah and another general surgeon tell us why it is Hartmann and why it is sigmoid. If you want, if you are a general surgeon and with Dr. Sabah, because I have listened to like a sigmoidectomy.
Yes, sigmoid colectomy.
Okay, but I need 2 surgeons or 4 or whatever general surgeons tell us the difference between Hartmann and sigmoidectomy.
Okay. In
Yes.
Hartmann,
Okay.
we do rectosigmoidectomy. We do sigmoid resection, and then rectal stump closing,
Distal
and
bar.
then last colostomy. 3 parts. This is Hartmann operation. Extended sigmoid resection, then rectal stump closing, then colostomy in Hartmann operation. But here, this sigmoid, we will do sigmoidectomy or sigmoid colectomy. Removal of the sigmoid colon.
Yes, sigmoid colectomy.
Would you hear me, Dr. Reda?
Can you once more summarize the differences, please?
Yes, in Hartmann operation, we do 3 parts. We start by removing the sigmoid colon. We do extended sigmoid resection. Then we close the rectal stump. After that, we will do colostomy. But in sigmoid colectomy, we remove only, not extended, just sigmoid colectomy.
So as discussed in iFiles, sigmoid cancer, obstructing cancer, or perforation, or diverticular disease, we will go for Hartmann. What's Hartmann? Like we said, proctosigmoidectomy with closure of the anorectal stump, and then the last one will be in colostomy. Okay, but if this sigmoid cancer is not obstructed, like Dr. Muhammad said and Dr. Sabah said, so we will do just sigmoidectomy with or without stoma. Could be done with primary anastomosis. And the happy news is, don't worry of all operative details and the stoma. Despite it's clear and we have clear notes, but now, as many surgeons knows, that any surgery could be done plus or minus stoma. Next one.
65 years old woman, 74 years old woman presented with weight loss and rectal bleeding as urgent colonoscopy reveals a non-obstructive tumor in the cecum. In the cecum. Please can be give option.
Of course.
Right hemicolectomy.
Yes. Okay. Next.
70 years old woman who was found to have anemia on their last admission as the hospital to the hospital has lower gastrointestinal endoscopic arrangement. She has found have high rectal tumor. High rectal. Yeah, anterior resection, I think.
Yes. Rectal tumor, which is high.
High
He will
as anterior.
give you the in centimeters, no problem. I will clarify this before in stoma. And you know all as general surgeons that this is anterior resection. We have high anterior resection when you have a tumor below the mesorectal reflection, the peritoneal reflection, and low anterior resection when you have a tumor below this reflection. But also, it's not important at all. Do some classification and the Gleason
can be continuous, doctor, or what?
Yeah, if anyone can continue with me, thank you, Dr.
Dr.
Sam.
I have question.
Yes, of course.
I'm a little bit confused between Hartmann operation and sigmoid colectomy. Someone of my colleague here asked why is the answer in question when is not sigmoid colectomy but Hartmann operation. And
Again,
I want to ask
one
you,
of your sigmoid, one of your colleagues saying what?
Of colleagues here, yes, before before minutes he asked why the answer in first question is not sigmoid colectomy, is Hartmann. And I think twice in the question, why is not sigmoid colectomy? Because in practically, it's Hartmann operation in emergency setting is better than, to do it better than sigmoid colectomy. It's a little bit confusing between both of this option.
I'm not talking in a practical at all. In practice, I know Hartmann. I told this in the previous recording in iFile. I told them that. Then I find people want to understand the MRCS and BUS test, and these people thinking in MRCS way. As we said, diverticular, perforated sigmoid, obstructing cancer sigmoid, then you will do Hartmann. Okay. Procto
Any emergency,
yes,
in the colon.
in emergency, and I will add the same sentence of Dr. Sabah, even not as an emergency, and read Medscape and read the Zollinger, and we know that it could not be an emergency, so it's Hartmann. But here he wants you to understand isolated sigmoid, non-obstructing tumor, do sigmoid colectomy. I don't know what's in practice.
In practice, like most of the time, the decision is taken because of the risky anastomosis. Even if it's in an elective setting, sometimes it's a risky operation to do sigmoid, and sometimes because of margin of tumors. So you have to go to the rectal area. So we have many times you have to do Hartmann more than sigmoid colectomy.
Of course, I'm with you.
Not common.
And you know what? That even anterior resection is done with a circular, without any stoma. So for a surgeon, if he is afraid from the leak, then he will do a stoma. But I know surgeons working and very good consultants going for no stoma, just primary anastomosis, and the patient pass very well. So it's not a general surgery issue, or it's not an NDT for general surgery. just simple as it is. Because I know Dr. Basim, he told me why you are showing us pictures. We want a word and the clue, nothing more for MRCs. So if I increase the dose this lecture, he will call me again. So try to be like MRCS way, just simple as it is.
Yeah.
Yes, it's Hartman.
So,
okay.
We need to pass the exam otherwise. This is the point.
Yes, I am with you.
So to conclude, Dr. Reda, we can say that the indication for Hartman operation is complicated diverticulitis and peritonism due to perforated tumor, for example. And the third is opinion of the surgeon. I think this is what I can conclude from our discussion, the indication for of Hartman operation.
Yes, it's just like a sigmoid problem. Either diverticulum is either perforated or obstructing carcinoma, then you will do Hartman. And I think this will be in the exam, nothing more. Like sigmoid colectomy, I haven't seen before, even in MRCS and past test. But
okay, thank you so much.
Many
thanks.
Many thanks, دكتور. اوكي احنا كنا مع مين؟ دكتور مين اللي هيبدأ؟ دكتور ليزا، دكتور علي او دكتور علي، دكتور علي حداد، دكتور علي هادي. Yes, go on, and then after Dr. Lisa. Okay.
A 67-year-old man presents difficulty passing urine. He has an elevated prostate-specific antigen and a transrectal biopsy is performed. I don't have a clue.
Gallstone score. Gallstone score.
Okay, Gleason. I haven't heard all these options, so if anybody else has some information about these options so they can answer these questions, I can answer the next questions.
Okay.
Yeah.
The first one, yes. يلا اللي هتكلم الأول, go on.
A 72-year-old man has a sigmoid tumor resected. The pathologist notes that the tumor is confined to the bowel wall and that there's no lymph node involvement. So confined to the bowel wall would be Jukes A. If it's confined to the mucosa, if it's beyond it would be B. So, Jukes B.
It's only in the mucosa, not going to submucosa or further.
So
Dukes A.
Dukes A.
Okay.
Dukes A. Number 3.
So a 45-year-old man presents with a 4-week history of fever, night sweats, and itching. He's lost 5 kilograms in weight over the last fortnight on examination and large lymph nodes. So that's Ann Arbor.
Brilliant. This is Ann Arbor for lymphoma staging. Next.
65-year-old woman has a colon tumor resected successfully. The pathology report states that the tumor has invaded the bowel wall. And there's multiple metastasis, so that's Jukes stage D.
D, distant metastasis, very nice. Next.
27-year-old woman presents with an irregularly pigmented lesion on her lower right leg, so that's Breslow thickness.
Yes, very good. For Gleason thickness, they multiply this by 2, and then they will conclude the risk of progression. In Dukes, it's very important, and the picture will be discussed in question posting in May. It's just a simple picture, like write on Google Dukes, and you will remember that if it's confined to the bowel wall, okay, invades the bowel wall, lymph nodes, C1 and C2, and also the distant metastasis. Ann Arbor for lymphoma, distant metastasis D, Breslow thickness for
multiple myeloma.
MM. Okay. Thank you, Dr. Lisa. Like that, she went for a full questions and she managed to know her level and then we can discuss. Anyone from you, Dr. Reda, I have a new idea, or I have a good discussion, or I have some problem to understand, so we can discuss. Like Dr. What is Dr. McBain? She told us about how should we proceed, and then she went. It was a administrative help, but where are you? Okay. Dr. Ali, احنا قلنا Dr. Lisa, then Dr. Who?
Yeah, I can read.
Yes.
Shall I
Okay,
proceed?
if you okay.
Yeah. A
Thank you, Dr. Lisa.
28-year-old man with Crohn's disease complains of watery discharge from a puckered area 2 centimeters from the anal canal. So I'm thinking of E.
What's E exactly?
Fistula in ano.
Yes, it's
Yeah.
fistula, buckering area. Okay, next.
Yeah, a 32-year-old woman who has recently given birth complained of excruciating pain on defecation that persists for hours afterwards. A rectal examination is not possible, so it is anal fissure. A 30-year-old taxi driver complains of tenderness from an area in the midline of the natal cleft, about 4 centimeters above the anus. The problem has been remitting and recurring for 2 years and has started discharge. So I'm thinking of pilonidal sinus.
Or abscess.
Or abscess. Tender. Yeah. A 27-year-old pregnant. Yeah.
Okay, you know, it's the same. It is an abscess, then can discharge through a sinus. So here, I think there is no pilonidal sinus, but it is the same idea. You know that the deepening of the hair in the natal cleft, the natal cleft is the area between, like if someone is a plastic and don't know, this is the natal cleft between the both areas of the buttocks. Okay, so this is a natal cleft. Here, hair drops, then invaginate inside, then a foreign body, then inflammation, then bus discharge. This is a pilonidal abscess and sinus.
Dr. Reda, what's the Pancreatitis area? Question number 1. What it mean?
It's mean a fistula, like a puckered area like this. It is already in the text box for description of the fistula. It means a puckered area like this. Okay.
Okay.
And I will show you a picture of this one on the group.
Okay. A
Next one.
27-year-old pregnant woman presents with constipation and bright red blood coating her stool. On examination, 2 bluish, tender, spongy masses are found protruding from the anus. These do not reduce spontaneously and require digital reduction. Can I see the options, please?
H, I think.
H. Yeah.
Rectal prolapse.
Or it could be K. I'm not quite sure which one to choose. I would go with K.
D.
No, not D. I'm thinking of K. Anyways, we'll discuss it later. Can I see the questions, please?
اللي هيجاوب هموته.
سامة خليك ساكت.
دكتور صباح ودكتور عدي, they are dying to tell us the answer.
Okay. And 19-year-old woman presents with multiple lesions around the anus. So this is the wart, I believe.
Very good.
Yeah.
So tell us from the beginning again, because I forget. Buckering, like, you know, in breast cancer, you have
Differing.
buckering. So the fibrosed area or inflamed area track the skin down. So it is just buckering. I don't know how you know it in a breast cancer. You will have a fibrosed area because of the cancerous process. Then it drag down the skin. It is felt and seen. So this is anal fistula. Next one, post-defecation pain. So it is perianal fissure. This is bilonidal sinus. And number 4, it is simple one. It is 3rd degree hemorrhoids. For you, hemorrhoids are grade 1, 2, and 3, and 4. It's not necessary for us to know what's grade 3 and 4, because I think it is advanced for you. هو اصلا كل اللي فات advanced يعني advanced for MRCS عامة. Okay, next one, doctor, you said.
Yeah, and wart for number 5.
Genital warts, like a papilliferous lesion, like accumulated or accumulata. The difference, like doctor said, it is painful with syphilis. Lata, it is flatta, not papillated like this. I name it lata as flatta. Okay, degree of hemorrhoids, 1st degree with no prolapse, just the Cushing, the problem in anal Cushing, just prominent vessels. Okay, 2nd degree, it is just a prolapse spontaneously reduced. So till now, not necessary for you as surgeons to intervene. 3rd degree, it is a prolapse, okay, and can be manually reduced, okay? But 4th degree is prolapse that cannot be reduced at all, okay? So for number 3 and number 4 grades, you have to intervene.
Dr. Reda?
Okay, yes.
For question 4, I thought I will answer with thrombosed bile. So
number 4.
The scenario is same as thrombosed bile.
But you have these do not reduce spontaneously and require digital reduction. This is a 3rd degree prolapse, manual reduction.
Also, thrombosed bile cannot be reduced.
Thrombosed will be very painful. Thrombosed or strangulated biles will be very painful.
Okay.
And it is not like
reduced by digital.
It's not reduce. You cannot reduce it simply. It is a biles collection of veins. But here again, constipation, bright red blood coating hair stools, 2 bluish tender spongy. This is our spongy masses. Here he hasn't told you about the description for this one.
So okay. it is 2 hemorrhoids?
Yes, 2 hemorrhoids, but the hemorrhoids are not associated with like a thrombosed biles. 2 bluish tender. But I think if you have for this description only, I will go with you, like maybe a thrombosed. But again, I don't think there's an option with a thrombosed biles. But again,
yes, no option.
Let's be more relevant. Like we have a grades of vials not to be thrombosed versus non-thrombosed. We have grades with prolapse, type 1 no prolapse, okay. Type 2 with prolapse can be manually reduced, spontaneously reduced. 3 manually reduced and 4 that cannot be reduced. Okay, if this only, you will go with thrombosed piles. Again, last tip, in the skin tags associated with the fissure, it is sentinel piles. Okay, so don't worry about the description of sentinel piles with fissure. Whose turn? Dr. Ahmed Agur, Dr. I have about 4 Dr. Ahmeds. If you open your mic, Dr. Shahmeen. Anyone new? Dr. Ayman
I'm
Rashid,
ready.
welcome. Who is ready? Who said I ready?
Dr. Ahmed Agur.
And Dr. Ahmed Agur and Dr. Ayman. Yalla, Dr. Ahmed Agur,
Yes.
then Dr. Ayman.
Yes, I also want to refresh this colostomy.
You want this one?
Can I see the answers, please? The choices. Okay. 65-year-old man is found to have a rectal carcinoma that is invading the anal.
انزل تحت كده.
Question. That is invading the anal sphincter. So it is abdominoperineal resection. Number H. Okay. Number 2. 69-year-old man is put to NNE with an acute abdomen. He is resuscitated and then taken to the theater for explorative laboratory. He is found to have a perforated segment colon secondary to a mass with malignant features. So it is Hartmann procedure.
Very good.
Okay. Number 3. 49-year-old man with a history of weight loss, anemia of unknown origin, is found to have a large cecal tumor on colonoscopy, right hemicolectomy.
Very nice.
Okay.
Next
Number
one.
4, 58-year-old man with a history of fresh rectal bleeding is found to have a tumor of the middle third of the rectum. Middle third of the rectum. So it is high اللي هو anterior section. Anterior section.
LAR or whatever, low anterior or it is anterior section, as long as it is upper or middle.
Yes.
Any question unclear from this?
And anterior section same lower section?
Yes, anterior section is 2 types: low anterior section and high anterior section, but not for MRCS. If you are not a surgeon, I know surgeons know this better than me, but this is not for us. It's anterior section, like written. I tagged you in the group.
This for lower
done
third
before,
of,
and it will be done later on in a new lectures. Inshallah, should be live. So don't worry.
Dr. Reda, this for lower third of the rectum?
If upper,
No.
if upper, if lower anterior third, you will do upper. Again, the rectum is 15 centimeters from the anal verge. Okay, from 6 to 4 centimeters mass away from the anal verge, you will do anterior resection with lobe ileostomy. Okay, if you have okay خلاص يعني انتوا عايزين.
Dr. Reda, can you explain the answer for third, please? What?
Okay, I have explained this, but So if this is the rectum and this is the sigmoid, okay, consider this is
The
15
third.
centimeters.
Can't
Yes,
see the drawing, Dr. Reda.
you can't see the screen.
It's just the questions.
Will be discussed, but okay.
Yes, now.
Okay, so consider this is the rectum, okay? If you consider that this is the anal verge and you introduce a colonoscope to see the maximum length, you will find it 5 centimeters. If you have any lesion at those 2/3, then you will do anterior resection. Anterior resection, then you will remove the tumor with loop ileostomy. Why? Because you will be doing a primary anastomosis, but you will be afraid from this primary anastomosis from leak. So how to do that? To divert the ileum to the tummy like this, as loop ileostomy. You will open the lumen to the skin. So it is a loop, temporary loop ileostomy. Okay? It is the ileum, I know, because this is with anterior resection. Some surgeons do not do this stoma, I know, but the old is anterior resection with loop, temporal loop ileostomy. Opening. Why? Because when you eat, the stool will be in a stoma bag, and you will do a rest for this anastomosis. Okay, so this known as anterior resection. Okay, but if you have lower 1/3, you have to do abdominal perineal excision of the rectum and colon. What's known as, you will do abdominal approach and perineal approach to remove lower 1/3 rectal or anal tumor. Okay, the remaining part. Okay. Okay, so you will remove this part and close the anus, right? This is known as abdominal perineal excision of the rectum. Okay, and the remaining end, you will do it as in colostomy. Why it's end? Because it is the end. Okay, it is one opening, and it is will not be reversed because you have no option to reverse it. Okay, so this is upper abdominal من here, and from here perineal approach to remove the lower 1/3 rectal tumor. Okay, so okay. Anyone want any problem, like as we said, upper or lower, upper and middle tumors, anterior resection with loop ileostomy. Lower 1/3, you will do upper abdominal perineal excision of the rectum. Okay, so below 6 centimeters.
Anal canal carcinoma, for anal canal carcinoma.
Anal canal chemo radio. Okay, if it's small, some surgeons saying it may be with excision, but mainly anal tumors, you will do chemo radio. Like cervical, esophageal cancer, you will do chemo radio. Like cancer, you will do chemo radio. Okay. Anyone want to understand any surgery regarding? Anyone?
Clear.
Next, we said who will continue with us?
Yes, Dr. Ayman Rashid.
يلا يا دكتور.
Should I answer?
No.
A 65-year-old
دكتور
patient
أيمن
has
رشيد الراجل جديد وعايزين نكرمه. فلازم هو اللي ينصر وإلا يزعل. طب أعمل إيه ساعتها؟
A 65-year-old patient has been suffering from frequent debilitating exacerbation of ulcerative colitis and would like curative surgery. We will do proctocolectomy with ileal pouch.
Very nice. Are you sure?
Yes, it's ulcerative.
Okay, for ulcerative colitis, we have two options.
Yes.
Yes. Which options?
Proctocolectomy with ileal pouch or ileostomy. Proctocolectomy with ileostomy.
Subtotal colectomy.
Subtotal colectomy.
Definitive surgery.
القلم خلص ولا ايه؟ Okay, we have band proctocolectomy and the remaining end of the ileum will be in the ileostomy. So ban means complete. Proctocolectomy, because it is ulcerative colitis, it would be extensive. So ban proctocolectomy with end ileostomy. The last portion of the ileum will be as end ileostomy. This is ulcerative colitis. Management definitive. Or, like you said, ileal pouch. By the way, in Bailey and Love, they prefer ileal pouch rather than endoleostomy. Okay, I don't know which one, but if any surgeon know which one, I'm here.
So I think in MRCS they given the choice for the patient.
In explanation in MRCS,
exactly.
they talk about the definitive surgery will be ileostomy, pan proctocolectomy with ileostomy. This is
But
the definitive.
here the patient, look to the patient. If the patient does not like stoma,
we'll do pouch.
We'll do EBA,
pouch.
Ileal, pouch, anal, anastomosis. Okay, if he no problem at all, then it would be proctocolectomy with ileostomy. Okay, so the option chosen here is F, proctocolectomy with ileostomy. If the patient said, I don't want this ileostomy or this stoma, we will do EBA, ileal, pouch, anal anastomosis. Next one.
Question number 2. A 28-year-old patient suffer from ulcerative colitis refractory to medical therapy. He agrees that surgery is required to treat his severe symptom, but doesn't want a stoma.
The other option. to colectomy with ileal
pouch. Yes.
Subtotal.
Subtotal for fulminant emergency surgery. You will do subtotal colectomy is ileostomy, but this is not fulminant disease or this is not emergency surgery. Okay. يلا في ناس بتنام. We want to
Number 2 or 3, doctor.
It's E. This is
لا, number
as the patient-
question 2. Okay,
C.
okay. I say about the number 3. Oh, okay.
Number three, a 30-year-old patient with ulcerative colitis is brought to emergency suffering from severe abdominal pain. A diagnosis toxic megacolon is made. It's for pan-proctoctomy.
No, ما هو دي
subtotal.
emergency بقى.
Subtotal colectomy.
Subtotal.
Toxic megacolon. Then you will do subtotal colectomy.
It is elective. Number 4, a 28-year-old patient with Crohn's disease present with complete small bowel obstruction. Small bowel
Strixoplasty.
This is multiple strixoplasty.
I don't know what's this operation.
Okay, if you have short versus long strictures, stricture-blast, you will do multiple excisions and the primary anastomosis of the small bowel. And by the way, this will eventually lead to small bowel syndrome. Stricturoplasty, it is, you will remove these strictures, okay? But by multiple measures because they are short.
How by multiple measure? How can we do that?
Okay. معلش انا عارفك انت بتتاوب يعني والله انا بتاوب انا كمان انا بشر برضه راجل زهق واتخنق
مايك
Okay, this are the strictures due to transmural cape lesion of the Crohn's disease. Okay, so these strictures need multiple strictureplasty. You will do excision and primary anastomosis. Excision and primary anastomosis. وتقعد تقص في الحاجات دي. Multiple strictureplasty. Okay, but if you have long single one, you will do resection and the primary anastomosis at once.
هيلاقيك واحد منهم.
Just Dr. Reda?
Yes.
I have just simple information I want to add in the stricturoplasty.
Of course.
If we had stricture up to 7 centimeter, we will do conventional stricturoplasty. More than 15 centimeter, we will do intermediate stricturoplasty. But in Crohn's disease, we'll do, as Dr. Reda said, multiple stricturoplasty. So here, no way for intermediate or conventional stricturoplasty. Yes. We will do just multiple, as Dr. Reda said.
Yes.
Simple information.
Down. Okay. الناس بتوع مننا. الناس اصلا مستحمله المعلومات بالعافيه ودكتوره صباح بتزيد معلش هو العدد كان 40 the number of candidates were 40 now 26 الطيارات كلها وقعت
26 okay
Dr. Reda please
and me it's so they are 25 okay yes
yeah Dr. Reda please can you repeat again about the stricturoplasty, please? I don't understand.
You want to understand Dr. Sabah? I don't know. She is talking about conventional method.
What you say? What you say about stricturoplasty, please again?
You multiple stricturoplasty. Like you will remove short strict and connect the rest of the bowel. But if you have a long one, do resection and anastomosis. Primary resection and anastomosis. So he said short, so stricturoplasty.
Thanks.
دكتور
Thanks a lot.
هيموتنا النهارده. ماشي. Next يبقى خلاص. Okay. Feeding. Very nice. I want you to understand feeding very well. Okay. So, anyone ready to answer?
Yes, doctor.
Yes, yes.
Yes.
All were ready.
Okay, anyone?
توكل على الله يا طيب.
A previous
Allah
healthy 22 years old man is admitted to the neurological ward after sustained moderate head injury from a high-speed road traffic accident. CT scan his head exclude any significant intracranial hemorrhage despite an initial Glasgow Coma score of 12. He being to exhibit a progressive sign of recovery. The short-term nutrition support is being considered for him.
Yes, so?
Yes. It's being
GT.
processed. In GT, I think. Huh?
No. Or
please,
you can
the
tell us,
answer.
is it short term or long term?
He being to exhibit progressive sign of recovery, short-term nutritional support.
أيوة. So
Short term.
Short term, so
Sure.
NGT.
NGT, I think.
very good. So
I
in
said NGT,
RTA
but
yeah, I know. I'm talking just to say it's
خليك
short
واثق
term.
من نفسك يا دكتور طيب.
انت طيب حتى. Okay, so in road RTA, road traffic accidents, if
Yeah.
said short term means 4 weeks to 6 weeks maximum. This would
Yes.
be NG tube, nasogastric tube. But take care, this is
About
not a
base of
skull-based
skull.
fracture.
Fracture
Then
based.
oral gastric tube will be preferred, and you will keep cautious. Okay. If
Okay.
said long term, then big percutaneous endoscopic gastroscopy.
BEG.
Very nice. Next.
72 years old man is admitted to the neuro rehabilitation ward with dysphagia, dysarthria, and left side hemiplegia after suffering massive intracranial bleeding. He is deemed unfit for surgery due to multitude for medical comorbidity and will require long-term nutrition supplementation. This
long term.
This is
Who
with his
afraid?
gastrostome.
Yes.
BEG.
Yes.
74
You
years
can
old
talk,
woman.
all of you. Yes.
74 years old woman undergo a Lewis Tenor procedure for a stage 3 carcinoma of the distal esophagus. She is not expected to undergo adjuvant chemotherapy due to the curative nature of the surgical procedure. However, she has lost 15 kilo in weight over the last 4 months, secondary dysphagia and malignancy, and will require long-term nutrition support. Jejunostomy, yeah?
Or big or parenteral.
Because operation the esophagus, we can't do BEG.
Yes, you go for parenteral.
For jejunostomy, I think.
Give option, doctor.
Okay, yes. Options. نسيت والله إن في options.
Jejunostomy feeding?
Jejunostomy feeding.
Jejunostomy feeding.
Because give another total parenteral nutrition, but if you give 2 options for per parenteral nutrition,
I go for TBN.
Please, the
TBN
question again, please, Dr. Reda.
For rupture.
Sorry.
Well, this question is advanced one, so it's not for you, really. يعني,
okay.
It's not even for us as general surgeon. Any general surgeon needs to answer, apart from Dr. Sabah. يلا دكتور صباح قول لنا الإجابة.
TBN because loss of weight 15 kilogram.
It's not the measure. It's not the same one. In the over the last 4 months, is not 3.
I think TBN.
So TBN,
Jejunostomy.
one of the indication of the TBN is
During jejunostomy, we have a long-term nutritional support.
My answer
So
is
TBN
jejunostomy.
is not suitable. We have to go for jejunostomy.
No, is it suitable for long term? Why not?
TBN.
TBN
Okay,
is
we will do
suitable for
NDT, and then we'll see. So I need you to understand this only. RTA, short term NGT, skull base, orogastric tube, long term percutaneous endoscopic gastrostomy. Okay. For esophagectomy surgery, you will do concurrent jejunostomy. For esophageal perforation, you will need TBN because of the intestinal failure. Short bowel syndrome, multiple intercutaneous fistulas. Any problem with intestinal failure, you will do TBN. Okay. I tagged you in nutrition cases on the group, but nothing more. He selected H.
What's H?
Jejunostomy, yes.
Yes, we asked.
Because of esophageal surgery.
Esophageal surgery. Okay. Yes. So I think it's already with us. So it is esophagectomy, then it's told for us as perioperative jejunostomy. Okay.
Yes.
Okay, he wants one. So together for RTA.
For RTA again?
Yes, for RTA. No, I think if there is base fracture or head trauma, we will use big.
Yes.
Or of the GLF fracture basis.
Yeah, if there is.
I already have the lecture done, and I have this from up to date. I don't know what you will do as surgeon, but it's written as oropharyngeal. If you have a skull base, I will show that after the end of the iFile. Okay, on the group, may I send it right now? Anyone is ready to answer this?
Okay, ready?
Yes.
Okay, doctor, I can read. If no one.
20.
Yes.
20.
Oh, go ahead.
23 years old female present to emergency department. Today, history of the severe lower abdominal pain and fever. Underwent to medical termination of the pregnant 10 days ago. An examination of the abdomen reversed severe suprapubic tenderness, and digital rectal examination is soft, tender, and fluctuating mass lateral to the rectum. Please can give option, doctor.
Okay.
Abscess, I think, pelvic abscess. I don't know. I think D.
Final answer?
Please give 22 female brain emergency part today history of pain. Underwent to medical termination of the pregnant 10 day Examination abdominal affairs, severe suprapubic tenderness, and yes, D, I think.
Pancreatitis.
Oh,
Pancreatitis.
okay, next one.
Give me question, doctor.
I showed you the detailed evidence based on the group that it's not big. They do oropharyngeal. Prefer as for RTA with a suspected skull base fracture. Okay, next, yellow.
58 years old diabetic female presented to the emergency department with 24 history of the severe right side, flying pain and fever, with chills and rigor. She currently taking oral antibiotic and received diagnostic urinary tract infection. Examination reveals tenderness and poor local mass in the right lumbar. I think pyelonephritis.
Mm.
45 years old man present emergency department with a 24-hour history of right upper quadrant abdominal pain, right upper quadrant pain, dizziness and pyrexia and pain into the right shoulder and the tip. He is recently underwent to repair of perforated duodenal ulcers 2 weeks ago. Examination, a subpharynx abscess.
Okay, next.
Another question, I don't see it.
So these are your
That's
final
it.
answers again. Number one.
Number one, I say pelvic abscess, I think.
Very good.
I think is
Pelvic abscess. Okay, next one. We will discuss later.
next one, pyelonephritis.
Pyelonephritis. Next one.
Next one, subpharynx abscess.
Anyone has any problem in these questions?
Number one, I think biosalpingitis, because it is localized swelling, localized mass.
Localized to the right or the left? It is suprapubic.
Suprapubic tenderness.
Lateral to the rectum.
Mass with PR examination.
So it is a pelvic abscess. It is localized to the suprapubic area. And sorry. So this fluctuant mass suprapubic, not biosalpingitis, and it's not bilateral, not written bilateral. So it is pelvic abscess still now. It is fluctuant, tender, suprapubic swelling. So it's pelvic abscess. Number two, it is severe urosepsis. So it is pyelonephritis. Okay?
Yes.
Plus the palpable mass within the right lumbar region. So it is right pyelonephritis. Okay? Number three, recent surgery. Again, as the previous question, this will be subpharynx abscess with a previous surgery. So here, again, pelvic abscess can occur following abdominal surgeries or gynecological interventions, even medical termination of pregnancy. Okay, thank you. Anyone ready to
Okay, sir, I can go?
Yes.
Okay, 44-year-old lady presented to the surgical outpatient clinic with a 4-month history of increased frequency of bowel motion, up to 10 times a day. The stools are associated with blood and mucus. She has lost 15 kilograms in weight during this period. Right sigmoidoscopy reveals an inflamed sigmoid colon and a number of small ulcers in the rectum. This may be ulcerative colitis.
Yes, it is ulcerative colitis. Okay. I will discuss later why. Okay, next.
Okay. 66-year-old man known to have inflammatory bowel disease is brought to the emergency department with severe abdominal pain. On examination, he appears pale and dehydrated and is febrile with temperature of 37.7 and tachycardia of 110. He has generalized abdominal tenderness and guarding. Plain abdominal radiograph reveals grossly dilated large bowel with a maximum wall-to-wall diameter of 6. This is toxic megacolon.
Toxic.
Very good. Next one.
77-year-old woman is brought to the emergency department with 3-hour history of severe colic, abdominal pain, and vomiting. Her blood pressure is 90/70, and her pulse rate is 112 with an irregular rhythm. Abdominal examination reveals. This is
mesenteric
ischemic colitis.
Embolus.
Okay, very good. So the first option, as we said, ulcerative colitis is superficial ulcerations start in the rectum and then go back to colon and may reach the terminal ileum, leads to terminal backwash ileitis. So with constitutional symptoms, the same constitutional symptoms of malignancy, but not malignancy because mucus, because this age is not of malignancy, because bowel motions, diarrhea, okay, blood and mucus, plus the inflamed sigmoid and this multiple small ulcers. So it is typical features of ulcerative colitis. And remember the age. You will find the Crohn's in a patient 20s to 30s, but ulcerative colitis may be bimodal above 40 years. And he will give you even histological or radiological finding of either Crohn's or ulcerative colitis. So don't worry about how to differentiate between them. Number two, it's very apparent, toxic megacolon. Because this is a dilated large bowel, okay, secondary to inflammatory bowel disease. So as we said, this is toxic megacolon. This is AF, then the embolus dislodged in the superior mesenteric artery or whatever the artery is. This is ischemic colitis with a bloody diarrhea, with peritonism. So it is mesenteric vascular occlusion leads to ischemic colitis. Anyone is ready? Apart
Yes.
from the previous doctor. Okay.
I'm ready.
Yalla go.
Yes, I am ready.
Okay, she and then he. Okay. Yalla.
34-year-old woman. This
Yes.
34-year-old woman present to her GP with 3 months history of intermittent colic abdominal pain associated with blood and mucus per rectum. Examination of her abdomen reveals moderate tenderness to palpation of the left iliac fossa. She remains hemodynamically stable and febrile throughout the consultation.
Ulcerative colitis.
This is ulcerative colitis.
So blood and mucus per rectum away from, if he said this is right iliac fossa,
it's Crohn's.
With mass, then terminal ileitis with Crohn's. But left iliac fossa should be colon or sigmoid or rectum. Yalla, next.
59-year-old mother of three present to her GP with 4-week history of intermittent diffuse abdominal pain and profuse diarrhea, lethargy and malaise. Her past medical history include recent total abdominal hysterectomy,
bilateral salpingo-oophorectomy, and omenectomy. Examination reveals dehydrated patient and diffuse tender abdomen. The patient hemodynamically stable and afebrile. Can I see the options?
Here you done tahbesso, which is total
Tahbesso.
abdominal hysterectomy with bilateral salpingo-oophorectomy. So now you have colitis, abdominal pain, profuse diarrhea with no fever. So the conclusion is radiation colitis. Okay?
Yes.
Because we have a cancer. Okay? So you supposed to expect that this patient had previous radiation. Next.
A 65-year-old man on the general surgical ward developed diarrhea on 7 days after pylorus reservation pancreatitis whilst receiving nutrition via feeding jejunostomy. Although pseudomembranous colitis is initially suspected as the result of post-operative antibiotic therapy, a stool culture subsequently excluded the diagnosis.
Nutrition.
هو السؤال فين؟
لا ده السؤال، هو ده السؤال.
answers.
ده انت عايز
questions.
والله ما فرقت حتى
malabsorption.
Zollinger-Ellison syndrome.
لا
ulcerative colitis.
No.
سؤال تاني دكتور مثلا.
gastroenteritis.
هو عمل اكسكلوجن للسودوممبرينوس كولايتس.
radiation enteritis.
ما هو لسه ما خدش حاجه الراجل.
malabsorption.
ما ضلش غير diverticulitis.
malabsorption.
gastroenteritis.
malabsorption syndrome. It's malabsorption. Yeah.
colorectal malignancy.
Okay, let's read
so read it together. Yes.
Okay.
Malabsorption.
We will supersede prerequisites that aims to cure pancreatic carcinoma.
Tertiary fever.
He's saying pseudomembranous colitis.
No, they have excluded. Yes, it is part, but they said they done the culture stool and they excluded it. So it is due to here is the answer.
Enteral feeding.
Diarrhea, isolated diarrhea, post-radical GI surgery may be due to pseudomembranous colitis or the feeding itself. If you have deranged liver functions, you have to think about TBN-associated deranged liver functions. If you have diarrhea, you can think about pseudomembranous colitis or the jejunostomy feeding with no chance to get absorption. So this is diarrhea due to enteral feeding. Okay, anyone is ready? The last one. I'm sorry, I know you are exhausted, but it's the last GIT.
Can I answer, please?
Yes, you can.
Acute bowel ischemia, acute gastric irritation, or dynamic bowel obstruction, anastomotic leak due to enterocutaneous fistula, early post-operative ileus, mechanical obstructions, other obstruction system, sepsis. A 55-year-old lady who has had multiple previous gynecological operations is admitted with abdominal pain, distension, and vomiting. She undergoes a laparotomy for division of the adhesions and release of the small bowel obstruction. The operation proved challenging and multiple peritoneal and omental windows to be made by the surgical registrar. Adhesions causing mechanical obstruction.
An examination happened is limited with hyperactive bowel
2
sound.
days after the operation, she still complains of abdominal pain and vomiting. On examination, her abdomen is distended and tympanic with hyperactive bowel sounds. Plain X-ray demonstrate distended lobes of the small bowel and
So it is internal herniation.
No. Leave
No?
him.
Pseudo obstruction.
Not pseudo.
Mechanical obstruction.
Yes, it is mechanical obstruction.
Mechanical.
Why? Because I know.
Because last row.
Hyperactive
because
bowel
what?
sounds excluding ileus.
Okay. Ileus means paralysis, so you will have no bowel sounds. But this hyperactive bowel sounds suggest mechanical obstruction.
Yes.
So, doctor, it's not internal herniation?
Maybe the cause is
yeah, because he's saying amontal window. Amontal window means the loop maybe.
Omental herniation due to, but we are talking the
maybe
type of
repaired.
obstruction, not as
not the cause. Yes.
Yes, not the cause. It is the omental window. You can
Causing
find internal
mechanical
herniation through this unclosed omental window. But we need it. Is it pseudo obstruction
or mechanical?
Or mechanical. So it is mechanical one. Okay,
Yes.
very good. Next one.
A 75-year-old male undergoes an anterior section for a sigmoid tumor. By post-operative day 7, his recovery is still suboptimal. He feels lethargic and he is complaining of vague lower abdominal discomfort. His vital signs reveals swinging pyrexia and tachycardia. On examination, his abdomen is soft but tender in the left iliac fossa. His bowel sounds are reduced and digital rectal examination reveals a tender boogie swelling anteriorly. Can I see the answers? Yes, lethargic, complaining of vague abscess, mostly abscess, anastomotic leak and abscess formation.
Yes, I think that.
Anastomotic leak and abscess formation.
Very good.
Yes.
Okay, anastomotic leak, it is from 2 to 6 or 3 to 7 post-operative days, and
Yes.
you have to put in mind after bowel surgery and resection anastomosis, you have to think about post-operative fever causes. According to the wind or the word I will send on the group, okay, we have like
wound infection.
From the beginning, we have post-operative fever, 38 Celsius degrees for 2 consecutive post-operative days, or 39 for 1 day. You have to remember 5 W's: wind, water, walking, wound, wonder, drugs. Wind atelectasis, air, means ear. So wind atelectasis, post-operative day 1 to 3. Post-operative day 1, 2, or 3. Atelectasis, pulmonary or lung atelectasis, or even pneumonia. Water, UTI, post-operative day 3 to 7, you have to think about urinary tract infection. Look at catheters, take urine dip and urine culture. For walking means venous thromboembolism. DVT versus pulmonary embolism. Post-operative day 4 to 6. You have to think about tachycardia, sweating, think about CTPA if you suspect that the patient has got PE, and for DVT, compressive ultrasonography of the leg veins, D-dimer, and it's a long story. For wound surgical site infections, post-operative day 5 to 7.
Angry wound.
Wonder about drugs, like which antibiotics written and given. Make sure that's given. And anticoagulants, make sure that you have TIDs and enoxaparin given, written and given. Okay, so this is the cause of post-operative fever. Anastomotically, as we said, this is post-operative day 3 to 7 with sepsis, with peritonitis. So you have to think about anastomotic leak. May be associated with peritoneal peritonitis, feculent peritonitis, internal fistula formation, or muco, even until wound dehiscence and enterocutaneous fistula.
Diagnostic by CT?
Diagnosis by CT. I know there is a difference between us about how to diagnose anastomotic leak, but in most scenarios in MRCS, they will select a CT. Next one.
27 years.
Yes, 27.
27 years old male with the recently episode of the right iliac fossa pain and leukocytosis. Undergo for open appendectomy. Intraoperative, the appendix does not look inflamed. His postoperative stay is prolonged due to wound infection, for which of receive intravenous antibiotic. His appetite remained poor and not tolerating solid food well. On postoperative day 4, the surgeon noted purulent discharge from the broken down wound and presence of gas bubble in the wound as the patient coughs.
Mesenteric adenitis.
Postoperative. The surgeon noted purulent discharge for broken down wound. Please give me option, doctor.
Gas bubble in the wound. Gas bubbles in the wound.
Enterocutaneous fistula.
Yes.
Enterocutaneous fistula.
Enterocutaneous fistula. Don't forget that this is a post-operative complication and associated with this picture, peritonitis. But he said told you he can told you that CT done and there is multiple fistulas connecting the intestine with the skin or gas bubbling or whatever. So this would be
يعني خرموا العيان وطلعوا.
Yes. Okay, last picture I want to show was it It's common in your exam. Gallstone ileus, to remember why someone asked me why pneumobilia. Simply, you have a complicated gallstone disease and paralysis of the small intestine, paralytic. Why? Because this stone will pass from a colidoco duodenal fistula, will pass and come here and will block the small intestine, leads to absolute intestinal obstruction. But why pneumobilia? Because this is GIT system is filled with air. So the air will escape and will be here. Don't forget that 90% of the gallstones in this are radiolucent, are black, not radio-opaque, not white. So 90% could not be appeared because they are radiolucent. Okay, so you will depend on the clinical signs. Intestinal obstruction, colidocoduodenal fistula with pneumobilia. Thank you, I have finished. I know you are loaded with many informations, but we have make it very simple, many scenarios, and anyone has any question can ask us.
Thank you, Doctor, for everything. It was really nice, interactive class.
Thank you. Thanks for everyone.
Thank you, Dr. Reda. Thank you.
Thank you very much, Dr. Reda. Thank you, all.
Thank you.
Dr. Reda, please. Thank you.
Any question? Again, I will go rapidly. Number 1, anal cancer, combined chemo-radio. Number 2, the competence of the anal sphincter is lost. Okay, so surgery in the form of APER. As we said, APER, lower 1/3 rectal tumor or anal. But necessary, we will need chemo-radio, but here is talking about that no need for the anal sphincter because it's lost. So APER in the form of abdominal perineal excision of the rectum and colon with end colostome. Number 3, downstaging for this very large rectal cancer. Not only anterior resection alone, but we will give pre-operative chemoradiation for downstaging.
Because it's large.
Yeah. What is the meaning of the downstaging? Just make it small.
Small in size to be here.
See, presents with a surgical outpatient with intermittent rectal bleeding, loss of weight. So it is a cancer, constipation, and diarrhea. Rectal examination, fixed growth of 7 centimeters from the anal verge. Okay, so
anterior section.
Downstage. Yes, anterior resection and downstaged by chemo. Low anterior, oh, it is anterior resection only. Forget about a high or low. It is anterior resection for upper or middle 1/3 rectal tumors. Thank you very much.
Thank you, Doctor. Thank you.
Shukran.
Thank you, Dr. Reda.
شكرا جزيلا دكتور رضا. شكرا.
شكرا دكتور رضا.
Thanks.